Aim of our education is not just to spread knowledge, but also to implement it for creating a better future. Guwahati, the heart of Seven Sisters, hub of education with a large number of colleges and universities. Students from all over Northeast come here with thousand dreams. With dream of having good education, better future and a good career. Aim of our education is not just to spread knowledge, but also to implement it for creating a better future. 5 kilometers away from the city, located by the bank of mighty Brahmaputra, spreading across Guwahati, a beautiful heart of Seven Sisters, acres, hub of education Assam with a large number of colleges and universities journey in the year. Students from all over Northeast come here with thousand dreams, with dream of having good education. They started with a dream and providing better placement to their students than the rest. Aim of our education is not just to spread knowledge, one has to also implement it for creating a better future. 5 kilometers away from the city, soon located by the bank of mighty Brahmaputra, with an infrastructure of nearly 50 lakh square feet of hub of education with a large number of colleges and 171 classes in the year. Students from all over Northeast come here. 108 labs and other modern and essential facilities like library, place better future, amphitheater, providing better conference hall to their students than the rest. Aim of our education is not just to spread knowledge, one has to also implement it for creating a better future. 5 kilometers away from the city, soon located by the bank of mighty Brahmaputra, with infrastructure with 75 lakh square feet of Faculty of Commerce and Management with a large number of Faculty of Humanities and Social Sciences in the Faculty of Engineering and Technology come here. 108 Faculty of Paramedical Sciences, other modern Faculty of Pharmaceuticals like library, Faculty of Nursing and Faculty of Hospitality, better conference hall and students sports complex. Presently, more than 8,000 students are studying from 7 departments also implemented on guiding centers more than 5 kilometers away from the city. Soon Assam by the bank of mighty Brahmaputra. Education doesn't really structure with 7 lakhs Faculty of Commerce and Management with a large number of Faculty of Humanities and Social Sciences in Faculty of Engineering and UGC guidelines and has all the necessary paramedical science and Faculty of Pharmaceuticals like library, Faculty of Nursing and Faculty of Hospitality, better conference hall and students. Presently, education is studying on the 7 departments and doesn't achieve guiding centers. Having an active campus life is one of the most downtown or healthy education doesn't really Assam downtown university Faculty of Commerce has a large number of Faculty of Humanities and Faculty of Engineering providing guidelines one has all the necessary paramedical science and Faculty of Pharmaceuticals like best Faculty of Nursing and Faculty of Hospitality. And yet, the government also centers on achieving guiding centers. Assam's downtown education turns the mirrors Assam downtown
we will take the attendance. Okay. Drawing from home. Oh. Ma'am, I'll click photo of the faculties for certificate.
A very good morning to one and all joining with us today in this 2 days virtual CNE on the theme Preparedness and Management of COVID-19 from Conception to Old Age. I am Anusuya Goswami, Faculty of Nursing, Assam Downtown University, and I will be the moderator for the morning. Foremost, I would like to welcome you all and express my heartfelt gratitude for taking your time out from your busy schedule and joining with us for this 2 days virtual CNE. It is my great pleasure to let you all know that around 390 are with us for this CNE through Zoom and YouTube Live. Eminent speakers from around the country have been invited who will be sharing their expertise knowledge on different sub-themes. Hope everyone new knowledge regarding COVID-19 and will be benefited by it. Now, I would like to welcome Dr. Anandatta Sir, Honorable Chancellor, Assam Downtown University, for a short speech.
I feel extremely delighted to learn that the Faculty of Nursing, Assam Downtown University has organized 2 days virtual CME on the theme Preparedness and Management of COVID-19 from Conception to Old Age from 26 July to 27. Nurses should be competent in delivering comprehensive care to the COVID-19 patient. With a panel of distinguished speakers from different parts of the country, hope this CME will be beneficial to all the participants in gaining knowledge in mental health and immunity management of COVID-19 patients. I wish you all the best for the session.
Thank you so much, sir. Next, I would like to request Professor Dr. N.C. Talukdar sir, Honorable Vice Chancellor, Assam Downtown University, to address the virtual gathering.
Namaskar and a very good morning to you all.
Good morning, sir.
And the Dean Faculty of Nursing, Mrs. Mansi Sengupta, and other colleagues from Faculty of Nursing, and very distinguished participants of this virtual continuing nursing education program organized by the faculty. As I see, there are almost 300 participants. It's very pleasing to know that so many participants, which signifies the importance of the topic on which this particular program has been organized. And I have also come to know there are very distinguished or eminent personalities in the profession of nursing who will be delivering lectures over the next 2 days for the benefit of the participants. At the outset, let me welcome you all to the Assam Downtown University in virtual mode. Like the very topic you have taken, COVID-19, this has compelled us all to remain confined to inside a room. Like it is always nice to have a seminar, workshop, or this kind of your faculty development program on digital mode. You get to interact with people more intensely. Nevertheless, what we have also seen in the past in this university itself, even last 1 month, we have been organizing quite a number of faculty development programs. And what was very heartening to note that the participants number were much more than what we get in most of the physically organized programs like this. And also we had privilege of listening to eminent speakers from all over the globes, not only from outside Northeast India, but also from outside the country. So that has been possible only. So it also has a very positive side. We have learned many new things and the technology development in IT sector. Like is it developing very fast for the benefit of the future generation. Let me at the outset, because this is a program of nursing people related in the field of nursing, let me first express my heartfelt gratitude to entire nursing fraternity who has played an extremely important role as a part of the healthcare teams all over the world in fighting COVID pandemic, in saving millions of lives. So I congratulate you all for the dedicated service you have put being in this noble profession. And this particular pandemic is very unique. Maybe after Spanish flu way back in 1918, I think the humanity has faced a much bigger challenge from this tiny microorganism, which has always been there since the like advent of Homo sapiens, mankind on this planet. This microorganism have been creating disturbance, upsetting balance, progress, but by virtue of the intellectual strength of humanity, we have overcome those. But this particular pandemic that last 1.5 years we have been still fighting is quite peculiar. Like the symptoms and other things, because I am not expert in the field. I don't belong to the medical profession, but what we read from the newspaper, like some of the very important journal, high impact journal like Lancet, when you read some article on those, you come to know that it's an extremely peculiar organism creating diverse city of symptoms. Even it varies with the genotypes. Like sometimes it may so happen that in the same family getting infected, each one of us has a different kind of symptom. So that's the complexity. And this complexity makes it very relevant that those who are involved in taking care of the patient suffering from COVID-19 infection, they need to really get the technical know-how or this knowledge on COVID-19 is emerging every single day, perhaps. So I find this is extremely relevant topic to our important program that nursing faculty has organized, and it's very befitting that you have been able to manage a large number of eminent speakers. I thank them all for agreeing to deliver lectures and benefit the participants. And I hope that this today's seminar will be extremely useful. And I also want to draw attention to our faculty members who have been joining and some master program students. As you know, the university is giving a lot of emphasis on integration of research and teaching. We are going to give much more emphasis on research aspect even in nursing faculty. So when you listen to this eminent speaker, look at, I'm sure some of them has personal experience of like personal research experience based talk they'll provide, and look at those very critically, what involves in generating new information, in dissemination of new information. So you should note down those, as I said, particularly master program students, that I hope many of you will go for doing PhD, because we have opening for doing PhD in nursing faculty. So I hope this will be a opportunity to learn about what involves for doing research, for generating knowledge, particularly in your field. And I'm 100% sure that eminent speaker will speech will throw light in this direction. With these few words, I wish a grand success of this today's program, and all the best. Thank you.
Thank you so much, sir, for your kind and encouraging words. Our first speaker, Parul Datta ma'am, has joined with us. Professor Vandana Datta ma'am, Dean of Studies, Assam Downtown University, to share few words with us.
I am very much glad that Faculty of Nursing has organized a webinar on preparedness and management of COVID-19 from conception to old age. Nowadays, whole world is suffering from COVID-19, and so many lives have been lost, and we are always afraid for affecting the COVID and we are vaccinated also, we are doing so many things. But nursing are the professionals who has to be contact with the patient. They are the person who has to take care of the patient in general as well as the COVID patient also. So I think for that it is very necessary to get training from the learned personalities of their profession. So they have organized the webinar in a good manner, and I am told that they have invited the learned professionals from different institutions of India, from AIIMS, from Mumbai, and from other parts of the country and abroad also. So that's all. That's why I thank our department that they have organized in a due time, and it will help all the professionals as well as the students who join this webinar. I hope in near future also they will organize this sort of training program for the development of their own profession with best wishes. And once again, I thank the department for organizing these things. I invite the learned person and the speakers of this webinar to our university when situations will be better. Hearty welcome to all of you. Thank you very much.
Thank you so much, ma'am, for your motivational speech. Next, I would like to welcome Professor Dr. Gitumani Kaur, ma'am, Director Research and Outreach, Faculty of Nursing, Assam Downtown University, for a short speech. Ma'am is facing some technical problems, so we will.
Anusha, your voice is not
Regarding
coming.
coronavirus and COVID-19. However, there might be some memory gaps to fill up those gaps and fresh. Let us welcome Professor Manasi Sengupta, ma'am, in Faculty of Nursing, Assam Downtown University, to give the overview of the theme coronavirus and COVID-19.
Very good morning to one and all present here. On behalf of Faculty of Nursing, Assam Downtown University, I heartily welcome Madam Parul Datta, who has joined, Dr. N.C. Talukdar, our Honorable Vice Chancellor, sir, and all other participants who have joined in this inaugural session. So, at the very outset, let me congratulate the organizing team and all the faculty members of Faculty of Nursing who has dedicatedly worked day and night for this particular CNE to happen. So hope it will be a successful one, and with all the eminent speakers all over the country, definitely we will be gaining so much of knowledge, in-depth knowledge of this particular disease, which is absolutely new, and so many things still we cannot say like has been invented or discovered. Still scientists are doing research day by day to get new information of this particular disease, its prevention, its management. So for this, we have taken the particular theme that preparedness and management of patient from conception to old age. So let me just take a little bit of revision, because all of us, we know that what is COVID-19, how this particular pandemic has occurred, how it has devastated the lives all over the world. So without much delay, let me share my screen with all of you.
Madam, in the bottom of the screen, you will be getting the share screen button.
Yes, yes.
Ma'am, I have already shared. You may continue.
Okay. Is my screen visible?
Yes, ma'am.
Okay. Fine. So a brief review on coronavirus disease and COVID-19. Next slide, Anushya. Yes, if you see here, coronavirus disease, actually it gave the name from as COVID-19, how it came as COVID-19. Usually it started from the time the disease has been invented and discovered. It was, the nomenclature was 2019 novel virus, or we can call it as novel coronavirus. Especially what is exactly this particular novel coronavirus? It is the severe acute respiratory syndrome, which we already have studied, that this is called as AR, or like we can say ARDS. In normal terminology, we say it is ARDS, acute respiratory distress syndrome, or here as the terminology has changed from SARS-CoV-2. This particular novel virus has taken its name and it has been changed to severe acute respiratory syndrome coronavirus 2. While the disease from the layman's terminology, we say, all of us in day-to-day life, we say it is COVID-19. Now, if you just see this acronym COVID-19, CO stands for the corona, VI stands for the virus, D stands for the disease, and 19 is the particular year where this particular disease has come into existence and it has devastated the whole world. Next, please. If you see virus, we all know what are the virus. We have studied in the normal microorganisms, the pathophysiological changes. Even a virus has ruled the world from many years. But this particular coronavirus, it's a family of large virus which usually causes illness in human beings. Other causes, it may also create illnesses in animals such as bats, camels, seabeds. Seabeds is a special kind of a cat. Now, human coronavirus cause mild illness such as common cold. So we all know what is a normal common cold, flu, influenza. We are all accustomed with this. But why this is so important, or what is this particular disease which is little bit of different than this flu and influenza? Severe acute respiratory syndrome, this is the SARS, which is a viral respiratory illness caused by a coronavirus called SARS-associated coronavirus. That's what whenever the diagnoses are written in the patient's case file or case sheet, it is written as SARS-CoV, that is the coronavirus, SARS coronavirus. Now, previously, this coronavirus have included SARS-CoV and MERS-CoV. What is the SARS-CoV? We'll know that is a severe acute respiratory syndrome, COVID virus. And MERS, it is the Middle East respiratory syndrome, which has already also, it was there as an epidemic, but it has not been declared as a pandemic, which has also has some influences over the southeastern countries. That's what Middle East respiratory syndrome, that is also related with the particular COVID virus. Now, severe acute respiratory syndrome or coronavirus SARS-CoV-2, which is a very new strain of coronavirus that has not been previously identified in humans. So that's what this particular disease, that is SARS-CoV-2, as I mentioned, it is absolutely new. Studies, researches are still going on from various parts of the country, as it has been identified first time in 2019 in the bodies of human beings. Next slide. Anushya, next slide, please. Yes, if you see the origin, as I mentioned, it was there, this particular family of viruses, it was there in the body of animals, like maybe bat or camel or sea bat, right? But this particular disease or this particular virus, it has in 2019, it has come into the body of human beings. The most likely ecological reservoirs for this particular coronavirus are the bats, because we have also seen in many studies, in newspapers, in media, that like in Wuhan, right, in the laboratory, they were doing some researches but for this particular virus in the body of the bats. But it is believed that the virus jumped from this species barrier to humans from another intermediate animal host. But still now it's a query, like whether we really know it has been transmitted from bat or from any other particular animals. The intermediate animal host could be a domestic food animal, could be a wild animal, or maybe a domesticated wild animal which has not yet been identified. That's what still researchers are going on, that whether this particular bat has transmitted the virus to the human beings or it has come from some other, either maybe from domestic animal or maybe some wild animal, so or maybe some domestic food animal. So still researches are going on. Next, please. Now you see, coming to this COVID-19, the virus that causes COVID-19 disease, I told you that it is a SARS-CoV-2. It appears to have first emerged in Wuhan, China in late 2019. And then this outbreak has spread across China to other countries around the world. And by the time the end of 2020, the new coronavirus has declared as a public health emergency by international concern and also by the WHO. The most commonly reported symptoms are, we know, is a fever, dry cough, tiredness. In mild cases, people who have been contaminated with this virus or getting infected with this virus may get just a running nose or a sore throat. In most severe cases, people with virus can develop difficulty in breathing or may ultimately experience organ failure. Sometimes, some cases we have seen, especially in the second wave, so many lives has been lost. So we also can say that this particular virus also is extremely fatal in case of severity of this disease. Next. Now, how we can consider that how suddenly this COVID-19 outbreak has happened. The WHO has declared the official new name for the virus that has also formally went by the name 2019 novel coronavirus or 2019 nCoV, is now known to be as SARS-CoV-2 or CoV-2, which causes COVID-19 disease. This name change is to differentiate it from another coronavirus outbreak that include the common cold, but also the severe acute respiratory syndrome, the SARS-CoV and the MERS-CoV, which have previously affected the world. But only difference is that this SARS-CoV and MERS-CoV were there in the previous time, but it has not been declared as a pandemic. It was there in this particular some parts of the country as an epidemic, but it has not been declared as a pandemic. But now this particular SARS-CoV-2, which causes coronavirus disease or COVID-19 disease, has come into an existence from 2019 December, and then WHO has declared is a total pandemic, which has devastated and causes so many lives in danger all over the world. Next. Now, little bit on coronavirus COVID-19 transmission and infection. How this particular virus is transmitted and how people are very often getting infected. Even with a small, kind of influenza, after testing, we get to see that we are getting positive. People are getting positive, and then how the cases have been increased day by day. Now, infected with coronavirus, as it has been declared as a pandemic, and community transmission also has so much in force. Infected with coronavirus, that is SARS-CoV-2, Usually, initially we have seen, we have even we have read so many newspapers, journals, about this disease, that it was previously through contamination of surfaces, but now it has been declared as it is present in the airborne. It has been declared as a airborne disease through aerosol, through droplets containing virus, which has been released by a contaminated person, and then these droplets can infect the other person. So usually when a person coughs, sneezes, this droplet containing virus in the air, usually it transmits within 1 to 2 meter in distance, and then droplets, either it falls on some surfaces or objects, and then on when touching those surfaces and objects, unknowingly maybe we have touched, and then these droplets through then with that contaminated hands, if we touch our eyes or nose or mouth, then the droplets eventually get into the nose and mouth, and then this starting with the disease has coming with the various types of signs and symptoms. And even in one case also, if you see here, the droplets land in the nose and mouth, and possibly directly it will land up into the lungs, creating so much of complications, rising with a sore throat, then developing cough, developing fever, because we know what are the initial signs of an infection for any disease. Next, please. Yeah, how it spreads? Usually it spreads through air, as I mentioned. Previously, we were knowing that it is contaminated through the contamination of the surface, even with touch, sharing with articles. And then if you like just hugging, shaking hands. So, but now as it has been given the name of airborne diseases, usually air by either by cough or sneeze, it try to contaminate or transmit from an infected person to the normal healthy person. And then through personal touch, contaminated objects, and then crowding, mass gathering. So through that, that's what so much of COVID appropriate behavior, we the health personnels are giving awareness that these things, usually wearing a mask, continuously use your sanitizer or wash hands with soap and water. Don't touch unnecessary things which have been lying down. Even if you have touched, just you wash your hands or you disinfect it with some sanitizer. And then try to avoid the public gathering. Try to maintain distance from each other. Next, please. Now, we have to know the difference between COVID-19 and SARS. COVID-19 and SARS, what is the basic difference between a COVID-19 and SARS? If you look into the COVID-19, the SARS-CoV-2, that is invented in 2019, community transmission. We have seen like why the cases have been increasing day by day. Why the sudden rise in cases? Because this particular disease have changed from a normal person to person, one person to one person transmission to a community transmission. Mass and mass of people are infected in a single day. And that is what through pandemic it occurs. So that's what the name COVID-19 is, a community transmission through pandemic. But in SARS, where we considered that previously the SARS was there in 2002, the MERS was there in those years. But why it has been not named as a pandemic and why it has not been named as a community transmitted diseases? Because there was no community transmission. It was epidemic. A particular part of the country was only suffering. It has not been given as a public emergency declared by WHO during that time. So that is the major difference between a SARS-CoV-2, which has been invented and declared as a pandemic because of the community transmission, and the normal SARS, what is there, normal COVID virus, the SARS which was there in 2002, there is no evidence of any community transmission. Next, please. Yes, as I mentioned, we still have a doubt, like, okay, we have a running nose, or we have body ache, we have myalgia, right? We have headache, right? These are normal symptoms of flu. After 1 or 2 days or 3 days, we go for a testing, then we got to see that we are positive of COVID-19. What is the basic difference between a flu and a COVID-19? The symptoms of flu, it begins within 1 to 4 days of after exposure. But in COVID-19, it takes the incubation period, it takes 1 to 14 days after exposure. You may not get the symptoms immediately after being contaminated with a positive patient. Then causes we know. In flu, we have so much of influenza virus. There are many strains which can develop normal cold and cough and influenza. And even we have seen our in children, we used to have a normal influenza shots also, like the vaccine shots also we were giving to our children during the time after the time they have taken birth, and they are with the normal immunization schedule, we go for the influenza vaccine. But the transmission, usually the transmission through respiratory droplet from an infected person, the influenza virus also the same way, but only the causes difference. In cause, in flu, it's a normal influenza virus, but in COVID-19, it's the SARS-CoV-2 virus. Now, complication in normal influenza, complications are very less to occur because of immunity build up over time. Our body is having that immunity to fight with the normal cold and cough, normal influenza. And in COVID-19, we see that usually it will start with fever. Sometimes nowadays we see most of the patients are asymptomatic. But when we go for a regular testing, we get to see that people are getting positive. The causes, maybe it may causes, it's a SARS-CoV-2 virus which has been infected in the body, causing fever, cough, fatigue, and complication. Directly it's affecting the organs. Especially severe respiratory complications may come on extremely quickly. And in this second phase, we have seen most of the patients are developing post-COVID complication affecting the lungs. In my subsequent slides, there are which are the complication which is occurring most in this particular phase of this particular pandemic. And then in flu, we know prevention, flu shot is the prevention. And here, in COVID-19, self-isolation. Once the person is getting positive, immediately he has to get himself isolated and put him into the quarantine as per the guidelines and protocol. Next, please. If you see this pyramid, if you see here infected cases so large, the blue color, we have seen so much mass and mass every day we are getting, see, cases are rising, patients are positive. Then in symptomatic, it's less again, because in this particular second wave, mainly the persons are having asymptomatic COVID-19 positive. Then hospitalized patients, and then we can see here in the extreme upper part, the ICU and the death. COVID-19, the clinical presentation, mild cases, no or mild pneumonia. 80% of people are complaining or are having this in this particular category of mild category. In severe, example with dyspnea, hypoxia, or maybe more than 50% of lung involvement in CT scan, within 24 to 48 hours, that reports to be 15% of the cases getting with the severe disease. And who are going to extreme critical phase, it is only the 5% landing up with respiratory failure, shock, multi-organ dysfunction. And basically we have seen people who are elderly age group and who have some comorbid problems, who had some previous comorbid health related issues. Yes, most of the mild cases can be recovered at home with flu-like symptoms. 13.8, that is severe category, pneumonia and shortness of breath, who requires hospitalization and who requires ICU treatment. 4.7% critical, who has respiratory failure, septic shock, and multi-organ dysfunction syndrome. Next, coming to the prevention, yes, we the healthcare providers, we are distributing pamphlets, leaflets, posters, and day to day we are giving information to our patients like wash your hands, use soap and water, avoid crowds, wear masks, avoid handshaking, and maintain social distancing. This is obviously now as small children also know what are the type of preventive measures we have to maintain at home, at our workplace, and everywhere due to this COVID-19. Yes, next. Now coming to a little bit highlight on this variant. Every day we come to know studies related to the variants. Like previously in first phase, there was different type of variant. In second phase, the colors are changing, complication coming to know that so many fungal infections are also then coming into existence, right? Treatments are different, protocols are different in ICUs. Now, these variants are very notorious. You know, in April, the WHO designated Delta as a variant of interest. In May, again, the WHO levels 3 variant as a variant of concern. What are those? The Gamma variant, which has been the existence is from Brazil. Then the Beta variant, the existence is from South Africa. And then the Delta variant, which is the absolute notorious variant, has emerged from our country, India. Delta has fast become the most worrisome of these 3 variants. Concern around the Delta variant is it's more transmissible than other variant, suspected to cause more severe symptoms. That's what, you know, the more cases we get to see, that maximum maybe, you know, number of cases who require the ICU, who requires oxygen therapy has increased from the first phase to this second phase. And in this later period, we have seen this particular Delta variant which has come into existence. Reported to cause breakthrough through infection even after 2 doses of vaccine. Yes, we come to that also has come into like notice and into the research into this particular worrisome cases. Like after even getting 2 doses of vaccine also, people are getting infected with this coronavirus disease. Now, COVID-19 symptoms first versus second wave. Now, high proportion of asymptomatic individual got admitted in second wave. Higher proportion of admitted patients shows breathlessness in the second wave. That's what second wave was very, very worrisome for us. Patients with a sore throat and dry cough were higher in first wave. You know, that is the reason, like, that's what it is important for us to understand the disease in depth. Now, question. This is a very recent article which I feel like to share with you all. Do you ever fully recover from COVID-19? Even some of our health personnel, we have even lost our health personnel, our nursing colleagues, you know, the doctor colleagues so much during first wave and second wave. Even we have lost our friends, our family, like so much of panicky situation, anxiety, fear when our near and dear one, our loved ones were admitted in hospital. So do we still, that question comes to our mind, do we ever fully recover? Some patients, some COVID-19 patients continue showing symptoms for months after initial infection passes. This is a study done by the health workers. Most common post-COVID-19 symptoms are breathlessness, neurological problems, including the thinking capacity, confusion, difficulty in concentrating for work, you know, insomnia, loss of taste, loss of smell are there, you know, and then continue to have headaches, mood swings, mood changes, extreme fatigue. Even after walking for 2-3 flights of stairs, people are feeling breathless even after coming back from hospital. 44% recovered patients have worsened quality of life. 78% of recovered patients show heart problems. The data has been given by the German doctors. 55 patients displayed neurological symptoms even after 3 months of initial infection. So from this, we can know that, you know, it's not that easy. So we have to have patience. We have to tell our patients that please stick with the protocol. Please be in touch with the doctors. Whoever is telling whatever the doctors, the guidelines, we have to ask them to maintain that. It is very, very important. So from my side, what is the take-home message from everyone who is hearing my overview of this particular theme? Be safe from coronavirus infection, be smart and inform yourself about it. Day to day, you need to study because day by day, the things are changing. WHO is giving so much of new updates. Even our India, our country is also taking initiative. Even Indian Nursing Council, TNIs are also taking initiative to give us update. And that's what we have invited speaker from renowned institution who has done this particular training and who are the member of the particular committee, expert committee in preventing and preparation of COVID-19 prevention aspects. Be smart and inform yourself about it. Be kind and support one another. So with this note, thank you so much for patience hearing. So hopefully whatever queries are there in mind, little bit, I'm at least I have tried to help you out, and remaining sub-themes, definitely our renowned speakers will highlight, and we are going to have a wonderful sessions ahead. Thank you so much.
Thank you so much, ma'am, for the I'd like to request Professor Dr. Kitumani Kaur, ma'am, Director Research and Outreach, Faculty of Nursing, Assam Downtown University, to address with her short speech. Over to you, ma'am.
Thank you so much, Anushya, for giving me this opportunity to address the gathering. We are very fortunate that today we all have gathered here to discuss regarding novel coronavirus disease, its conception to all this. As we have among us 390 participants, we feel Faculty of Nursing is blessed with all over the country that all the participant has joined us, as we have various eminent speakers from all over the globe, and I believe that we are going to have a very fruitful this 2 day session, and we are going to learn many new things. I offer my thanks to our honorable Chancellor Sir, Dr. N. Dr. Shah, and Vice Chancellor Sir, Dr. N. Sitalukdar, who has highlighted about the importance of the today's session. And as we know that the novel coronavirus who has knocked us during the December 2019, that first case was detected. Then very within a short time, by March, it has been declared as epidemic, then pandemic. All of us, we know how it has shaken the world. A small, very small particle has shaken the human civilization, or what we say human, whatever technology we have already, but still everything was shaken by it. But still then, because of all our technology, latest innovation, we are able to handle everything very to little late, but still we are able to handle everything. As the cases were very high during the second wave also, but still then again it has come down. And now from the experience, whatever we have learned from the first wave as well as second wave, we are we are preparing for the third wave also. As we go back, if we go back and look at the our previous scenarios, we learned from the history, right? So if we look at the swine flu or other polioviruses and so on, in every pandemic, it has taken at least 5 years, and the world is sick. If after every century there is a big pandemic like this, so we are aware and we are learning, and we have seen, although there were very much problems because of pandemic virus, economy has gone down, healthcare facilities we have to strengthen, but still then there are many opportunities. There are many opportunities, and in this we are with this opportunity still we are trying to handle all the situations, and as we are handling the various situations, various hospitals has come up, new tech like oxygen plant has come up, then mechanical ventilators has come up, and our health sector has been strengthened many folds than prior. So it is a one opportunity for us also when healthcare facility is strengthened and it has been multifold than before. The previously ICU strength in a hospital used to be 10 or 12. Now ICU strength in a hospital it is 200, 300. That means there are need of the nursing staff is much more what was prior. So now, as the world was not able to know what the nursing staff, nursing people are doing, or the necessity of the nursing people, or the importance of the nursing people, the people comes to know when they're old, when they goes to the hospital, that time they knows what is nursing professionals or how much the nursing professionals know. And as the people goes in the old days, there is very according to my opinion, less scope to publish to the society that nursing professionals are very, very important person, and there is nursing professionals are a integral part of this healthcare professionals. Now, novel coronavirus or SARS-CoV-2 has given us a very, very good opportunity to prove ourselves. So we are able to prove ourselves. We are able to prove the nursing professionals. And other thing, what I was telling, as because of that many fold of the increasing number of healthcare facilities, opportunity of a job for the nursing professionals is quite high now. So what we have to learn now, we have to learn the skills, we have to grab the opportunities, we can go for starting the startups, we can start our entrepreneurship. So many things has come up. Even if all of us, if we want, we can even start our own colleges, own hospitals. So these are the opportunities also coming us. So not only look at the government jobs, not only look serving the people, look to become entrepreneur. So wish you all the best, as we have very eminent professionals of nursing from all over India. We have among us Madam Parul Datta, retired principal nursing officer from West Bengal. Then we have Dr. Lily Puddar, associate professor, Nursing College, All India Institute of Medical Sciences, Bhopal. Then we have with us also Madam Lakshmi Gandhi, Professor, Head of Nursing from NIMHANS, Bangalore. Then Madhuri Gawas from Assistant Nursing Superintendent for Sefi Hospital, Mumbai, Maharashtra. Dr. Bhuvaneshwari Ji, Community Health Nursing from Sabita College of Nursing. So all this eminent personality from the nursing, we have Susan and we have invited them to speak on the various topics about the theme. So I wish all the participants a very fruitful learning and wish all the resource person very best for the upcoming days. And on behalf of Assam Downtown University, welcome you all for this today's session, and hope that this CNE will give a very important steps in the nursing profession, and we are able to create and give a mark or year mark in your learning or in your future, whatever you are serving to the people or in your career, we are able to give some opportunities. Thank you so much. Thank you all. Once again, thank you everybody. Over to you, Anushya.
Thank you so much, ma'am, for your inspirational words. To have with us, Ma'am Parul Datta. Good morning, ma'am. Warm welcome, ma'am.
Good morning to everybody. I'm audible?
Yes, ma'am. Yes, ma'am.
Okay. Good morning to everybody. Good morning.
Good morning, ma'am.
Good morning. I'm audible? Voice is clear?
Yes, ma'am.
Okay.
Ma'am will be speaking on the topic preparedness and management of children against third wave of COVID-19 pandemic. Ma'am is a very popular figure in our nursing fraternity and has rendered valuable services towards nursing, especially child nursing. from West Bengal Nursing Services, and she has about 40 years of experience in neonatal and child health nursing. Ma'am is a master trainer of facility-based newborn care, and she is the Vice President of Indian Association of Neonatal Nurses. Ma'am is also the author of the book, Pediatric Nursing, which we have all studied in our nursing profession, I guess. Ma'am is also the recipient of National Florence Nightingale Award from President of India in 2008. Very welcome, ma'am. Over
Thank
to you,
you.
ma'am.
Thank you for my brief introduction, and very good morning to all who are participating in this program and in this CNE, and thanks organizing team members, everyone, for giving me this opportunity to share my experience and information to these gatherings. I think everybody will be able to gather some information and enrich themselves from my presentation. And I think please share my slides.
Is it visible, ma'am?
Yes, make it a full screen. Make it
Yes,
full
ma'am.
screen. Okay, I think it is visible to everyone.
Yes, ma'am. Yes.
Yes. Again, thanks the full organizing team members for giving me this topic as preparedness and management of children for third wave of COVID-19 pandemic. It's my honor to present my topic here. So next slide, please. Next slide. Yes, outline of my presentation is, after introduction, I will just briefly describe about coronavirus and COVID-19. Already, Professor Manushi has given an excellent overview of coronavirus and COVID-19. I will give a brief overview, and then I will discuss about preparedness for COVID-19 among children in third wave and about COVID appropriate behavior for prevention of this third wave surge. Then I will discuss about some points, important points about general measures for prevention of COVID-19 in this COVID situation. And then about clinical presentations, what we used to find in the children and in the neonates, along with the management of children with COVID-19. Recommendations for management of neonatal COVID, special recommendations I will highlight about from the Government of India recommendations and from WHO also. And then some points on infection prevention and control measures, and then nursing responsibilities for these COVID in pediatric population, and then some key messages. Next slide. In the first slide, I like to describe about the case scenario of a child with COVID-19, what we are facing in our clinical situations. A 7-year-old child brought to the COVID triage area with fever for 4 days, cough, throat irritation, headache, and vomiting, with history of COVID in the family members. On examination, the child's respiration is 50 breaths per minute and SpO2 is 92% without any other signs of respiratory distress. So whenever any child with this type of clinical presentations come to the COVID triage area as a suspected COVID, because the family has, from the family, the child is having an exposure. So first, in the triage area, what we have to do, we have to classify the child's illness, whether the child is having mild, moderate, or severe illness. From these presentations, you will find out this child, as the child is having fever for 4 days, cough, throat irritation, and headache, vomiting, and respiration rate 50 breaths per minute and SpO2 90. With these features, we can classify the baby is a moderate case of COVID-19. And then we have to decide where we will admit the child or will send this child for home isolation. We will not send this child for home isolation, because on home we can care the asymptomatic children or any asymptomatic COVID patient, or the mild case we can manage at home. So this moderate case of COVID, we have to admit in a dedicated COVID health center or in a COVID hospital. So these questions you will get in details in answer in my presentation. So now in the next slide, I will describe about some important points. Please, next slide. Next slide. So already, so with this information about what type of patients we are getting in the COVID area, triage area, or even in the general emergency also. So with this type of questions, first we have to clarify what is COVID-19 and what does. Already Professor Manushi Sengupta has given a details overview. Just to summarize that points, I like to highlight some more important points. That is, we know that it is a viral disease caused by a newly identified coronavirus in 2019 at Wuhan, China. That's why it is known as COVID-19. It is a highly infectious disease and presently found as pandemic throughout the world from January 2020. Incubation period of COVID-19 is approximately 2 to 4 days with an average of 5 to 6 days. For that, remembering this incubation period, the quarantine period for COVID-19 should be at least 14 days from the last exposure to a confirmed case. It can be, some state government is recommending for 17 days also. So mode of transmission, already we have listened from previous speaker that mode of transmission of coronavirus are by direct contact transmission, droplet transmission, and airborne transmission. And what we have aware about the COVID-19, that COVID vaccines are available for prevention for the adults only, including pregnant women and lactating mother. COVID vaccines for children are not available at present, but are in trial and in research process. Very soon we will get the COVID vaccine for children also. There is in trial run. Few trial center is in India. They are in trial for 12 to 17 years of age. And in Western country, they are having vaccine trial for the children, even from the 6 months onward. So I think in near future, we will have the COVID vaccines for the children. Okay, then one thing we have to keep in mind, there are no drugs specially approved for the treatment of COVID-19. So what we have to do, any problem, please mute. Please mute. Who is talking? Please mute.
I request the participants to kindly mute their microphones.
So there are no drugs specially approved for the treatment of COVID-19. Only the symptomatic and supportive treatment we have to provide, and that is our responsibility. And we have to remember that mortality due to COVID-19 is mostly influenced by presence of comorbidities like asthma, diabetes, heart disease, malignancy, etc. So if any child or any person having comorbidities, that person should be treated meticulously and with very sincerity. We have already experienced the first wave of COVID with maximum number of cases in 24 hours, about 1 lakh. That was the peak incidence. But in second wave, it was more than 4 lakhs with proportionate increase in all age group. And what we are in prediction that in third wave, children may be affected more in number as they are not vaccinated, and they can get infection from the adults, family members, and parents also. So that's why in third wave, we are very much worried and stressed about the childhood COVID. So we have to prevent that. So we have to maintain our preventive measures, and we are the nursing personnel are the frontline worker in the community, in the facility, or in all places. So we have to promote more about the preventive measures. Next slide, please. Next slide. Is it not moving? Okay. So already my previous speaker has given details about that, but we have just to review. Positive organism of COVID-19 is coronavirus, also known as SARS-CoV-2 RNA virus. That RNA virus, what the structure, this picture shows the structure of that coronavirus. The red spikes are the spike glycoprotein, usually that attack the human epithelial cells, and the green spike, that is envelope protein, that also, and that spike, both spike, that envelope protein and the spike protein, they are attached to the membrane. And in the inside the virus, there is nucleocapsid and RNA, that RNA component coding for the spike protein. So with this, mainly the spike protein attack the human epithelial cell and react with the human epithelial cell and produce the different categories of disease. Next slide, please. So from our previous experience, what we have seen in first wave and third wave, we have to be prepared for management of COVID-19 in the next upcoming surge. So this slide, I will just discuss about the what, how, and how we will prepare ourselves. Most important thing is we have to prepare and practice we have to prepare ourselves by practicing COVID appropriate behavior and by modifying our lifestyle in this COVID situation. We cannot live as the pre-COVID type of lifestyle. So we have to live the post-COVID and new normal lifestyle to survive in this pandemic situation. Another preparedness, we have to vaccinate ourselves as appropriate, and mainly now adults are getting vaccination and also as available in our locality and in community. So third preparedness is most important, is the vaccination for COVID. And most important from the healthcare providers point of view, the preparedness is to make ourselves aware about the early identification of COVID signs and symptoms and triaging and prompt initiation of COVID management. And it is our responsibility to make the community people for early identification of COVID signs and symptoms, and to bring that child or that affected person or suspected person to the health facility for immediate and appropriate. Important preparedness is revamping of health facilities and infrastructure for COVID treatment. Already we have seen in first wave, due to huge number of cases, first and second wave, there was scarcity of hospital beds, scarcity of oxygen therapy, and scarcity of ventilatory support, even management facilities for all types of cases. So that's why this time from the health sector delivery system, so reorganization of the available health facilities, pediatric beds and adult beds is already, adult beds are rearranged. Now pediatric beds will be rearranged along with the availabilities of oxygen support, ventilatory support, ICU care or HDU care, or available medications as recommended for the children. So that we have to prepare beforehand. Another important preparedness is capacity building of healthcare manpower and support service system. If we are not enriched ourselves about the latest information, latest guideline, because we have learned that the that coronavirus is changing every day and the manifestations is also changing every day. Till now, it's a new, as it is a new disease. So we are not having that much of evidence to support and to practice the evidence-based care for this COVID. So for that, whatever new information is we are receiving, so we have to apply and we have to find out the better way to manage these COVID cases. And another important for the management and preparedness for COVID in children is the involvement of the parent and family members. Without parent and family members, it is difficult to manage this situation only by the healthcare providers. And also the community involvement is another important point. Already there are so many NGOs are working, self-help groups are working, local clubs members are working. So we have to involve them all in, if really the third wave is hit us, or if there is the more children are affected, because when the children are affected, then the family members, especially the parents, become overwhelmed, stressed and anxious and burnt out. So that time community support is very, very important. And for that, stress management and improvement of mental health in all aspects, for the family, even for the healthcare provider and the community people, we have to improve the mental health of all. So then that is another aspect of preparedness. And another important aspect, what we have to do, more scientific research work we have to perform to get the evidence support and to follow the evidence-based practice guideline. And with that, I think we will be able to fight with the upcoming third wave for all categories. Next, I like to just highlight, this is recommended by Government of India and WHO, and there is 15 COVID appropriate behavior. Already previous speaker highlighted about some points, but I like to just briefly, I like to describe about the 15 COVID appropriate behavior recommended by Government of India and WHO. First behavior, greet without physical contact. Don't touch anybody. Maintain 6 feet distance. Do gaj ka duri between 2 persons. Minimum distance 6 feet, because now there is chance of airborne transmission. So to prevent airborne transmission, we have to maintain minimum distance of 6 feet. Number 3, we are homemade reusable face cover and mask. This is for community people to prevent the community transmission. Those who are working in the facility or the healthcare providers, they can use N95 mask, but the community people can use 3 layers of even homemade mask, but surgical mask can be provided to the patient or family members when they reach the facility. Then avoid touching number 4 is avoid touching eyes, nose and mouth unnecessarily. We know the main entry of portal of entry of coronavirus is mainly eyes, nose and mouth. So we should not touch frequently. Then there will be chance of, even with the contaminated hands, if we touch eyes, nose and mouth, there will be chance of corona infections. Number 5, maintain respiratory etiquette. So use of handkerchief and coughing in the elbow. Already these informations are there, but we have to practice these meticulously, this COVID appropriate behavior to prevent the next upcoming surge. Number 6 is the hand washing facilities frequently. Hand washing we have to perform frequently, minimum 1 minute hand washing, following 6 steps, using soap and water. Liquid soap will be best, but even any soap, with soap and water hand washing, because soap will break down the glycoprotein and membranes of the coronavirus. So soap is very important. Use of soap is very important. Number 7, COVID appropriate behavior. Don't chew tobacco, khaini, etc. and don't spit, because that will transmit the coronavirus from the as a droplets or even in the as a airborne transmission. Number 8, regularly clean and disinfect frequently touch surface with available disinfectant, mainly alcohol-based disinfectant or whatever is available. We have to clean and disinfect the frequently touched surface, even at home, in facility, everywhere, even office, everywhere we have to practice this. Next slide. Next slide, please. So this is number 9, COVID appropriate behavior is avoid unnecessary travel. We like to travel, we like to go to tour, but it is very important to remember that unnecessary travel and can make exposure to the asymptomatic COVID person, or there can have exposure to super spreader also. So unnecessary travel we have to avoid. And we have to avoid crowded place to protect ourselves from getting infection. We have to download the Arogya Setu app on your mobile phone. Then you will get regular information from the government side. And in number 12, don't discriminate. Number 12, COVID appropriate behavior is very important. We have to remember and we have to follow that we should not discriminate against anyone. and any person who is associated with or who is suffering with COVID-19 or associated with COVID care. Like if our neighbor is infected, any person in our neighboring family is infected, we should not reject them. We should not isolate them. And even the healthcare provider, COVID care from the COVID care center, doctor, nurses, and other health team members, if they are rejected from the society, this discrimination should be avoided, because this will create more panic situation and more stress and burnout, and that will prevent the fighting for the upcoming event if it is coming at least with a huge surge. So number 13 behavior is seek information on COVID-19 from credible source. Don't get misinformation and confused yourself. And number 14 is, in case of any symptoms like cough, fever, and difficulty in breathing, call National Helpline 1075 or any state number to get help. From there is now the online teleconsultation is available, online consultation is available. So you have to, with any symptoms, you have to identify or suspect yourself as a case of COVID. Before testing, you can be a case of suspected COVID, you can get the infection. So you have to consult with the teleconsultation. You can consult. Number 15, COVID appropriate behavior. Seek always psychological support from a authority who is able to provide psychological support when you are stressed and burnt out or you are anxious. Because this panic situation, everybody, we are isolated at home, we have to do work from home, so we can have mental stress and problems, so we have to overcome that. So here I have highlighted some general measures. This is for psychological upliftment of our own health to fight this COVID pandemic. First is the boost the immunity. So first we have to de-stress ourselves. We have to remove our stress, and we have to learn how to remove our stress. We have to relax, we have to sleep well, take healthy diet, we have to perform regular and moderate physical exercise, we have to avoid drugs, alcohol, and vitamin supplementation we can take as advice, and we have to maintain healthy physical relationship, physical and mental relationship with family, friends, and colleagues, even in workplace. Because these COVID situation, now there is great fighting among the family members, even the husband, wife, even the parent and the children, adolescents. So they are having unhealthy relationship between the family members, even with the friends. So we have to overcome that abnormal behavior to boost our immunity, because when we are anxious, when we are angry, then our body system will act against our immunity. So that will deprive our immunity. So we have to keep these all things in our mind. So we have to build our resilience. We have to stop panicking, stay mentally strong, positive, and even-minded. We have to practice calmness, so that all individuals can develop their own strategy to practice calmness, along with the recreational activities and diversional activities. And another important general measures we have all as available. We have to get vaccination as age appropriate. Now adults are only getting, and how much we are it is available, we have to get that vaccination. We have to arrange previously. We have to overcome the skepticism, and we have to learn about the vaccine availability, safety, efficacy, timeline, and variants and adverse reaction. In our country, till now, 3 vaccines are available. So judge what is available in your locality, learn about the safety efficacy of that, and the interval between the 2 doses, that also you have to learn. Don't criticize, because our getting vaccinated for all people will be difficult, because our India is a huge populous country having 140 crores population, and vaccination to all people will be very difficult. So gradually we will be vaccinated. We will, after infection, we will get immunity, antibody in our body. We will be able to protect ourselves. With asymptomatic infection, we can have our antibody. So with that way, we have to vaccinate whenever we get chance. We have to vaccinate ourselves to get protected from this COVID situation. Another important practice guideline for home isolation we have to follow. It is already available from the government side, from state government and government of India. You can follow that. I will give some points in my later slides. And we have to remember one thing, that we have to know that lockdown is better than being dead. So few years or now at present 2 years we are locked down almost. So that things we have to, then afterwards I think we will be able to overcome this lockdown situation. So in that way we have to accept this lockdown, and we have to beat our boredom during this lockdown, and we have to think balanced and think positive. Then we will be able to adopt and adjust with this COVID pandemic and panic situation. We have to be socially responsible. We should not over consume food, drugs. Even people are consuming medical equipments like oxygen concentrator, pulse oximeter, everything. They are even huge vitamins and huge medications they are consuming and storing in their house. But I think it is then for that those are already affected, they can have problems. So we have to be socially responsible. We can help our neighbors, and we can share whatever we are having. We can share our resources to other people. Then we have to learn about the basics of COVID treatment, especially the management of fever, use of oxygen when oxygen required, benefits of prone position, use of antibiotics, steroids, remdesivir, and other treatment, what will be available and where it will be available, that available facilities in your locality and nearest area. You have to get all informations beforehand as a preparedness. And overall, we are all believe our Almighty. So we have to embrace spiritually, and we have to live healthy cultural. We have to promote our healthy cultural belief with the heritage of our Indian origin. I think this will help us to prepare to fight with the next upcoming surge. Next slide. So with this slide, just briefly, I like to highlight about the clinical presentations of COVID-19 in children at a glance. The clinical presentation can be little different from the adult, but older children means adolescents can have the similar signs and symptoms as like adults, but the younger children and infants and neonate can have the different clinical presentations. With remembering that points, I like to highlight these signs and symptoms. What can we find in the COVID pediatric group of COVID with the pediatric group of population? So most common symptoms, all we know, that is fever, cough, rhinorrhea, sore throat, throat irritation, body ache, headache, malaise, weakness or anorexia, nausea, vomiting, loss of smell, sense of smell or taste, skin rash, and now also so many new sign symptoms like arthritis or joint pain. These are adding every time due to changing in variants of the coronavirus. So most important problem is respiratory problem. So for differentiation of signs and symptoms and classification of cases for management purpose, we have to classify in 3 groups, that is asymptomatic, 4 groups: asymptomatic, mild case, moderate case, and severe case. Asymptomatic and mild case children can have the above symptoms, common symptoms. Other than that, respiratory rate per minute will be in normal range as age dependent variation, and SpO2 on room air will be 94% or more. But in moderate case of COVID-19 in children, there will be rapid respiration with age-based variation and SpO2 between 90 to 93%, more than equal to 90%, but less than 94%. And respiration will be age-based variation. What we usually know, that less than 2 months of baby can have respiration as rapid respiration 60 or more breaths per minute. And then 2 months to 12 months, it can be for rapid respiration will be considered when it is 50 or more breaths per minute. For 1 to 5 years of age group of children, when the respiration is 40 or more breaths per minute, then it will be considered as rapid respiration. Or in case of 5 years or more age group of children, when the respiration is more than or equal to 30 breaths per minute, then it will be considered as rapid respiration. So in moderate cases, along with the common symptoms, the child can have rapid respiration and SpO2 90 to 93%. In severe cases, that rapid respiration, age-based variation will be there. Along with that, there will be SpO2 level will be less than 90% with presence or absence of grunting, severe retractions of chest, lethargy, somnolence means sleepiness, and seizures or convulsion. With this, whenever we receive any baby or children with these signs and symptoms, we have to classify in this child in the triage area. Then we have to plan for the further management. With this idea of clinical presentations, I will now discuss about the management of different categories of COVID affected children. First, I like to highlight about the management of asymptomatic COVID-19 in children. Who will be the asymptomatic child? That is the suspected contact from the parent or family member for any other persons, and rapid antigen test or RT-PCR test is negative, or the test is not done or not available, or children are having no symptoms but incidentally detected when the family members are affected. Then if incidentally the COVID testing is done, then with the rapid antigen test or RT-PCR, the child can have positive. Child having no symptoms but child can be positive, that case should be considered as a symptomatic COVID in children. And the mainstay of treatment is, for these children, no such management is required. Only the infant or younger children will allow to stay under immediate care of the parent and guardians at home. No specific medications required for this COVID-19 infection. Continue medication for other conditions if the child is having like asthma or nephrotic syndrome or any heart disease or any congenital malformation or leukemia or any malignant condition. So that management should be continued. No disruption of that other conditions management should be done. And we have to promote the COVID appropriate behavior for all, including the children. So I will tell about the use of mask for the guideline for the use of mask for the children. So COVID appropriate behavior, already I have discussed about 15, but for these children we have to use 3, that is use of mask, strict hand hygiene, and physical distancing we have to maintain. And the guideline for use of mask we have to follow. And we have to remember that if the child's age is less than 5 years, we will not give the mask to use that child. But 6 to 10 years of children can use mask with supervision by the parents or any adult caretaker. And above 10 years of age child can use mask as adult with some instruction. Another point of management of asymptomatic children with COVID is we have to allow adequate fluid and feeds to maintain the normal health of that child. We have to ensure oral fluid intake to maintain hydration, and we have to give nutritious diet, especially it will be homemade food and it will be easily digestible diet should be given to the child. For the older children and family member, we have to advise to stay connected and engage in positive talk through phone and video calls. Otherwise, the child, if the older children are placing in a room, in a home isolation, then that child can have the stress and anxiety and loneliness and boredom. So to overcome that, parent can visit and parent can have continuous phone call or video call with that. But for younger children, no separation from the parent or caregiver should be done. Parent and caregiver always for this asymptomatic case should contact the doctor in case of appearance of any new symptoms in the children. So for these few points we have to remember that child with asymptomatic COVID will be managed in home isolation along with teleconsultation whenever necessary. No investigation required in these asymptomatic cases. Only what parent we have to teach for red flag sign, and parent has to observe or caregiver has to observe for red flag sign of COVID-19 to refer for facility level management, because if the child is having red flag sign, then child require facility level management, then home management will not be possible. In case of management of mild cases of COVID-19 in children, child usually present with that common symptoms of clinical presentation with sore throat, rhinorrhea, cough without any breathing difficulty, and SpO2 less than 94% in room, more than equal to 94% in room air, or with other symptom as I have discussed in the previous slide. So mainstay of this condition of mild case of COVID in children is first is the management of fever. And for that, we have to give paracetamol 10 to 15 milligram per kg per dose. We all know these things, and we may repeat it every 4 to 6 hours. If the child is having cough, then give throat soothing agent or warm saline gargle in older children or adolescents. Don't do the self-medication. Consult your doctor by teleconsultation, and then ask for the throat soothing agent and use that. Or you can give just a little warm tea, warm drinks, like that we can give for throat soothing agent to the children, for younger children. For older children, we can give warm saline gargles. And again, we have to allow fluid and feed, ensure oral fluid to maintain hydration and give nutritious diet. No other COVID specific medications needed in case of mild case of COVID. Antimicrobials are not indicated in mild case of COVID. But one most important thing, we have to teach to the parent and caregiver about maintenance of monitoring chart, and that monitoring should be done by counting of respiratory rate per minute 2 to 3 times a day. We have to teach the parent how to count respiratory rate, and then we have to teach the parent how to look for chest indrawing and respiratory other difficulties, and urine output, oxygen saturation, fluid intake, activity level, especially for young children. Older children can express their difficulty, but young children cannot express their feelings and their problem. So parent or caregiver has to observe and monitor these signs and symptoms. So here also we have to promote COVID appropriate behavior, and we have to follow the guideline for use of mask appropriately, covering the nose, mouth with 3 layers mask. And we have to advise the older children, as they can take care of themselves, and the family members to stay connected and engage in positive talk through phone and video calls. And parent and caregiver can contact the doctor in case of deterioration of symptoms. From mild symptoms, if there is any deterioration, then can have moderate and severe symptoms, and then that child requires the facility level management. So for that, they can consult doctor or teleconsultation. So again, we have to remember the mild case of COVID in children can be managed in home isolation with teleconsultation, or if the space is not available at home, that mild case COVID child can be admitted in COVID care center. No investigation required for mild case of these children, and we have to, and parent or caregiver has to observe for red flag sign of COVID-19 for referral to facility level management. Next slide. Next slide. So what monitoring will be done by the parent? So taking training of the parent and explanation is required. Already I have highlighted for home care of COVID children as following: maintaining of monitoring chart of the affected child, counting of respiratory rate per minute 2 to 3 times a day while the child is not crying, looking for chest indrawing, nasal flaring, bluish discoloration of the body, cold extremities, urine output, monitoring of oxygen saturation with age appropriate specific handheld pulse oximeter. Adult pulse oximeter will not assess the SpO2 for the children. So for the age specific, if it is available, it should be age specific pulse oximeter to assess the oxygen saturation. Otherwise, oxygen saturation can be measured by the doctor or in the health facility. Monitoring of pulse rate is also very important. Body temperature by thermometer should be monitored regularly along with the GI symptoms and presence of other clinical features. Communication to doctor should be done by the parent along with the whether the child is having good prognosis or any deterioration. So that consultation and communication should be done with the nearest doctor and with the by teleconsultation, and whom to contact in emergency and when to bring the child to the hospital, that should be explained to the parent. Worsening sign, again I like to highlight worsening sign and red flag sign, that is breathing difficulty with a rapid respiratory rate with age-based variation, chest indrawing, nasal flaring, bluish discoloration, reduced activity, lethargy, poor feeding, altered sensorium, seizure or hypoxia if monitoring of SpO2 is possible. The red flag sign include rapid breathing age-specific variation, SpO2 less than 94%, fever persisting more than 3 days with drowsiness, poor feeding, and these conditions need facility-based care for COVID management. So next slide. Next slide. That is management for moderate COVID cases among children. Here some symptoms will be as mild cases. Along with that, we have to check for signs and symptoms of pneumonia with rapid respiration, with age-specific variation, and SpO2 in the range of 90 to 93% on room air, and with presence of other symptoms as I described in the previous slide. Mainstay of treatment is initiation of oxygen therapy that should be done in moderate COVID in children with the SpO2 where the SpO2 is less than 94%, and we have to maintain target oxygen saturation will be 94 to 96%. We have to maintain fluid and electrolyte balance. We have to encourage oral fluid and allow breastfeed if the infants are on breastfeeding. And if the parents are not, children are not able to allow the oral feed, and if the child is not able to take the oral feed, and if the child is not with breastfeeding, then we have to initiate IV fluid therapy when the oral intake is poor. Corticosteroid, we have to remember that in case of moderate COVID, corticosteroid are not required in these children in moderate illness. They may be administered when the condition is rapidly deteriorating. In case of fever more than 38 degrees centigrade, paracetamol should be given. Antimicrobial should be administered in case of moderate cases if there is evidence or strong suspicion of superated bacterial infections, and we have to follow the use of microbial agents guidelines for the children. Supportive and symptomatic care for comorbid situation to be continued. These moderate cases should be admitted in dedicated COVID health center or in COVID hospital for facility-based management. And they require admission, investigation for CBC, ESR, blood glucose, and chest X-ray. Mild and asymptomatic cases don't require any investigation, but moderate cases require tier 1 investigation with CBC, ESR, blood glucose, and chest X-ray. Parent and family member can be allowed in the COVID hospital or dedicated COVID health center along with the child to take care of the child during their care or management protocol. Next slide. So management of severe COVID in children, I will highlight briefly these children present with SpO2 less than 90% in room air and with any of the following features, that is signs of pneumonia, respiratory distress syndrome, septic shock, multi-organ dysfunction syndrome, or pneumonia with cyanosis, grunting, nasal flaring, chest indrawing, lethargy or somnolence, seizures, and other symptoms as described in the previous slide. Mainstay of treatment, again, oxygen therapy with target SpO2 90 to 94%, maintenance of fluid and electrolyte balance. Mainly these children require IV fluid therapy. Corticosteroid should be initiated in severe cases as per recommended dose. Anticoagulants may be indicated. For that, recommended dose of anticoagulants should be followed for pediatric age group. In case of acute respiratory distress and shock, if develops, we have to initiate the management of that condition as per guideline. Antimicrobial should be administered to the severe cases as evidence and strong suspicion as per antimicrobial guidelines. And these children, severe cases, may need organ support in case of organ dysfunction. Mainly the renal replacement therapy may be required. These children, the severe COVID cases, required admission in AdtU, that is high dependency unit or intensive care unit of COVID care hospital. Investigation required other than CBC-ESR blood glucose, CRP, liver function test, kidney function test, serum ferritin, D-dimer, and chest X-ray should be done in case of severe COVID cases. Next slide. So management of ARDS in brief, ARDS as per standard guideline that we have to classify according to the presence of clinical manifestations and all conditions. We have to classify the child as mild, moderate, and severe ARDS. The mild cases of ARDS should be managed with a high flow nasal oxygen therapy. 0.5 to 2 liter per kg per minute oxygen should be given with continuous monitoring. And if required, non-invasive ventilation as BiPAP or CPAP can be given along with the symptomatic and supportive care for the mild ARDS. But for moderate to severe ARDS, the children required management with lung protective mechanical ventilation as per recommended guideline for the children with FiO2 less than 60% and PEEP 6 to 10 centimeter of water. And we have to use during invasive ventilation, we have to use the cup TT tube. Few points for this aerosol generation we have to keep in mind. We have to avoid frequent disconnection of ventilation circuit. We have to avoid open suction, so we have to perform inline suction. We have to avoid nebulization or meter dose inhaler for the therapy. We have to restrict fluid intake and we avoid fluid overload that can complicate the conditions of ARDS. We have to initiate enteral nutrition within 24 hours of initiation of management and achieve full feed by 48 hours. Prone position can be done with supervision, and in case of hypoxic children, if they are able to tolerate it, daily assessment for weaning from the mechanical ventilation should be done, and early extubation should be practiced to prevent extubation related complications. Blood transfusion may required in case of hemoglobin level less than 7 gram per DL in stable oxygenation or hemodynamics, or if hemoglobin is less than 10 gram per DL, if refractory hypoglycemia or shock is present, then blood transfusion may be required for this severe ARDS. So management of shock in children, we all know the shock is a state of acute energy failure due to inadequate oxygen delivery, glucose substrate delivery, or mitochondrial dysfunction at cellular level. And we have to evaluate for detailed clinical manifestations carefully for the signs and symptoms of shock. And we have to manage with crystalloid fluids 10 to 20 ml per kg of body weight cautiously over 30 to 60 minutes using syringe pump or infusion pump, or we can use vasoactive supportive agent as epinephrine. We have to start antimicrobial within first hour of taking blood culture as per hospital antibiogram. We have to administer inotropes, milirinin or dobutamine if poor tissue perfusion is present or with myocardial dysfunction persist after vasoactive agent, and achievement of target mean arterial pressure we can provide, we can administer inotropes. Hydrocortisone may be needed, that definite indications we have to follow. And once stabilized, we have to restrict IV fluid to avoid fluid overload. We have to initiate enteral nutrition. We have to keep in mind sooner enteral nutrition is having better prognosis. And transfusion we have to consider according to the level of the hemoglobin. Next slide. Another most important aspect, what though it is not rare, but it is rare. Next slide. That is multi-system inflammatory syndrome in children. Next slide. other than ARDS, other than shock, children may present with us at multi-system inflammatory syndrome. And multi-system inflammatory syndrome in children, briefly it is called as MIS-C, is a new syndrome characterized by unremitted fever for 3 days and epidemiological linkage with SARS-CoV-2. Diagnostic criteria as per WHO, the children and adolescents 0 to 18 years of age having fever for 3 days and or more and having 2 of the followings along with other 3 markers. The other 2 features, 5 features, among that 5 features, if 2 are present, we can diagnose the child as a MIS-C. So that 5 features are rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammatory signs at oral region, hands and feet, hypotension or shock. Third is the features of myocardial dysfunction, pericarditis or valvulitis or coronary abnormalities. Fourth is the evidence of coagulopathy, increased D-dimer, PTT, and acute gastrointestinal problem like diarrhea, vomiting, or abdominal pain. And along with fever and any 2 of these features, if there is an elevated marker of inflammation, that is ESR is more than 40, CRP more than 5 milligram per liter, or procalcitonin, increased procalcitonin should be considered, and no other obvious microbial cause of inflammation like bacterial sepsis or septic shock syndrome is not present, and evidence of recent COVID-19 infection, RT-PCR, antigen test or serology test positive, like contact with other parent with COVID-19 should be there. So considering these all clinical evaluation, we have to diagnose the MIS-C. And alternative diagnosis we have to exclude, like tropical fever for malaria, dengue, staph typhus and enteric fever, and toxic shock syndrome due to staphylococcal or streptococcal bacterial sepsis we have to exclude. And another thing we have to keep in mind that MIS-C can be associated with Kawasaki disease phenotype, which is characterized by fever, conjunctival redness and or cracked lip, strawberry tongue, rash, swollen or erythematous hands, feet, or cervical lymphadenopathy. So this is a very critical situation. We have to identify and we have to manage. This is those who are working in the facility. We may have though the numbers of not that much, in third wave it can increase. So that's why the awareness and our information, we have to enrich ourselves with this information. So for management of MIS-C, first in recommended investigation as tier 1, tier 2, all investigations should be done. And MIS-C is managed into 3 categories. That's MIS-C with shock or MODS, means multi-organ dysfunction syndrome, is managed with IVIG and methylprednisolone antimicrobials. If symptoms persist or worsening happens, then we have to consult for specialist. Management of Kawasaki type phenotype also can be managed with IVIG and methylprednisolone with the standard recommended dose. If symptom persists for 48 to 72 hours, or if early worsening, then we have to consult for specialist. Management of MIS-C without shock is managed only with IV methylprednisolone 1 to 2 milligram per kg per day, and if symptom persist, then we can think about the phenotype to which this condition evolution occurs. But along with that management of MIS-C, we have to provide supportive care in ICU or pediatric ICU with tapering of steroid, use of aspirin therapy, CRP monitoring, low molecular weight heparin therapy, along with ECG and echo for echo monitoring, along with the cardiac involvement. So just to summarize about the special recommendations for management of COVID in children, COVID-19 is a viral infection. So antimicrobials have no role in management of uncomplicated cases. So we have to keep these things, non-rational use of antimicrobials should be avoided. Justified use of microbials should be done. In asymptomatic and mild cases, antimicrobials are not recommended for therapy or prophylaxis. In septic shock, empirical antimicrobials are frequently added as per clinical judgment. Steroids are not indicated and are harmful in asymptomatic and mild cases of COVID. It is indicated in critically ill COVID and under strict supervision in right dose and right duration steroids should be given to the children. Remdesivir is not recommended for children. Anticoagulants are not indicated routinely, only in case of thrombosis. The children should be monitored for the features of thrombosis, then only low molecular weight heparin in therapeutic doses after confirmation by investigation of thromboembolic phenomena, we can use anticoagulant. CT chest is not indicated in diagnosis of management of COVID-19 in children. Suggested standard pro forma recommended by Government of India for monitoring of the children should be followed in COVID care units. Meticulous practice of infection prevention and control measures must be practiced. Use of mask are not recommended for children aged 5 years or below. Already I have discussed. So just out of my own interest, I like to highlight about some neonatal conditions, because neonatal pathology and neonatal clinical manifestations is totally different from older children and adults. So we have to keep in mind neonate can present with early onset COVID, and that early onset neonatal COVID usually often remain asymptomatic with positive SARS-CoV-2 PCR test before discharge from the hospital. Only 1.6% of infants born to COVID positive mothers can have early onset neonatal COVID. I have seen 2 days old neonate is having COVID positive and COVID symptoms with respiratory distress. Commonly remain asymptomatic, detected by routine testing. Perinatal transmission or vertical transmission is uncommon, but it can happen from the placental infection. Commonly, the manifestation, early onset manifestations found in 2 to 7 days after birth, and manifestations are temperature instability. Even the neonate can have hypothermia or low-grade fever. Neonate can have loss of interest of feed, nasal congestion, flaring or nasal flaring, irregular breathing, bluish discoloration of periphery, lethargy, poor feeding, and GI syndrome, diarrhea and vomiting. Next slide. Next slide. Late onset neonatal COVID, usually the neonate readmitted after discharge from hospital at 5 to 35 days of age. The neonate infant can present with temperature instability, lethargy, feeding intolerance, apnea, and respiratory distress. Usually it occurs due to postnatal transmission from mother or family members or caregiver. Child on admission usually present with desaturation and tachycardia. You can find 89 saturation and 180 heart rate. And during chest X-ray, you can find non-specific opacity, and in blood examination, we can find leukocytosis, lymphopenia, and thrombocytopenia. Next slide. In neonates, MIS-N, multi-system inflammatory syndrome in neonates can happen, though it is very rare. It happens due to maternal lymphocyte infiltration, antibodies, and due to neonatal hyperimmune response. And it occurs due to maternal COVID past and present infection. Mother usually infected. From that, the neonate can have this MIS-N. Neonate present with myocarditis with increased troponin and increased BNP, and or can have an coronary aneurysm, or neonate can present with DIC, that is disseminated intravascular coagulopathy with decreased fibrinogen, increased D-dimer, and thrombocytopenia, neutropenia, or lymphopenia can happen. Neonate can have desaturation and tachycardia. You can see 192 heart rate. Can have respiratory problem as hypoxemia, pulmonary infiltrates in case of persistent pulmonary hypertension of neonate. Neonate can have GI problem as feeding intolerance, vomiting, and NEC, or that is necrotizing enterocolitis like presentation. Neonate can have renal problem like hyponatremia, oliguria, renal failure, or anasarca. These presentations are little different from the older children. Next slide. Next slide. So just special recommendations for management of COVID pneumonia in neonate. We have to keep in mind that we are having the few fact we have to keep in mind. We are having limited experience for management of neonatal COVID due to less number of neonatal COVID in our clinical and clinical situations. There is limited information and evidence support for COVID in neonates. And the management protocol recommendation is similar to pediatric age group with symptomatic and supportive care like other conditions. And there can have overlapping with perinatal neonatal disorders like prematurity, asphyxia, or congenital anomalies that should be taken into consideration during management of COVID pneumonia. Because neonate can have pneumonia due to bacterial sepsis, or neonate can have pneumonia or respiratory distress related to prematurity due to surfactant deficiency, or in case of perinatal asphyxia, or in congenital surgical problem like congenital diaphragmatic hernia or tracheoesophageal fistula, the neonate can have respiratory distress. So we have to exclude all that conditions. So what are the recommendations? We have to follow precautions in delivery room. We have to practice rooming in, breast milk feeding with mother's own milk, kangaroo mother care for low birth weight, and these practice should be promoted. COVID appropriate behavior and infection control measures to be followed strictly. Communication, counseling, and schedule follow up should be continued. Routine immunization as per schedule and family participation also must be continued. Home-based care of neonates should be supported by community health worker and with discharge counseling. Community health worker, ASA can help, ASA, ANM, Anganwadi worker, even community health officer or local doctor can help for home-based neonatal care. Thank you. For next slide. Next slide. So this picture is not clear, but you can get it from the reference I have given. In the delivery room, the area should be divided into two areas, that is delivery area and resuscitation area. There will be minimum 2 meter distance between delivery table and resuscitation corner. Hand hygiene in delivery area, hand hygiene facility should be there, and all team members should wear full set of PPE with N95 mask, and delayed cord clamping should be practiced along with immediate skin to skin contact. Mother's oxygen saturation should be monitored, and if required oxygen saturation if less than 94%, then oxygen therapy should be given to maintain normal oxygenation. And in resuscitation corner, one standby support member should be there. One person should be involved in first resuscitative procedures, and one recommendations are to avoid routine oral and nasal suction and to avoid endotracheal route of medications. If suction and intubation is required, then we have to use plexiglass head box to prevent aerosol generation prevention. And then oxygen saturation of the newborn should be monitored. For PPV and PPV with self-inflating bag or TP's resuscitator, we have to use disposable tubings, and that should be discarded in color-coded container as per BMW guideline. And all reusable articles should be disinfected immediately. One thing we have to keep in mind, we have to avoid bathing of the newborn born to the COVID positive mother, because these are malpractice are going on in some places. So we have to avoid bathing to prevent hypothermia and in risk of infections. So we have to choose the area of neonatal care if the born to the COVID positive mother. If mother is 4 category we have divided. If mother is whether mother is COVID suspect or COVID positive and baby is stable or more than 34 weeks, then we will divide into A and B. C is mother COVID suspect, baby sick or less than 34 weeks. D is mother COVID positive and baby is sick and less than 34 weeks. These classification will be done in the delivery room, and before admission of the neonate, classification should be done for neonate also, and ongoing or periodic assessment should be done during the course of illness. If the baby is COVID suspect and stable or COVID positive or stable, then we have to think whether mother is sick or not. If mother is not sick, just in the left corner you can find out, we will allow rooming in, and mother and baby will be allowed to stay in COVID postnatal ward with direct breastfeeding and droplet or contact precautions. But if mother is sick, then baby will be shifted to well baby COVID ward, and if mother can express breast milk, then baby will be feeding with EBM, or if it is not available, then formula feeding should be given. If baby is COVID suspect, neonate with gestation less than 34 weeks and sick, gestation less than 34 weeks and sick and suspected COVID, then baby will be admitted to COVID suspect area of SNCU and NICU. Same if the baby COVID is positive, gestation less than 34 weeks or sick, then baby will be shifted to COVID positive area in SNCU and NICU. This is the organization of SNCU and NICU. I am not going in details. Just in the donning area, main NICU, doffing area and counseling area. Donning area, hand hygiene and PPE wearing area should be there. Just previous slide, 1 minute, I will just previous slide. In NICU and SNCU, minimum restriction will be attendance, minimum person will be entered and no mobile will be entered, and all distance, minimum distance, hand hygiene and disinfection procedure should be maintained. In doffing area, there will be hand hygiene facilities and disposal of PPE. In counseling area also, disinfection of frequently touched surface and distance should be maintained, and explanation should be given about visiting policy. Next slide. So this is decision tree regarding breastfeeding. This is not visible clearly. So this is available from government website. This is recommended by Government of India and WHO. You can find these things. Next slide, I will explain in next slide. Next slide, please. You can download this decision tree because breastfeeding we have to promote, and so what we have to, these three scenarios is there. If rooming in and direct breastfeeding is possible, then nurse should assist in lactation, mother should follow the hand hygiene, we are masked to maintain respiratory hygiene, and we have to explain that breast milk will help to transfer specific immunoglobulin, that is passive immunity, from mother to baby, and there will be promotion of bonding between mother and baby. And if mother is not able to take care continuously, then between the mother and baby 2-meter distance should be maintained, and the healthcare provider or nurse can take care of the baby using all precautions of disinfection and wearing of PPE. If rooming in is not possible, then mother will, and direct breastfeeding is not possible, then mother will express the milk, and for that mother will perform hand hygiene before and after expression, maintain respiratory hygiene using mask, and dedicated breast pump should be used, and disinfection of all the expression articles should be done after each use, and careful transportation of EBM should be done to the baby to avoid contamination. Any healthcare provider or nurse can feed the baby with EBM with the spoon or paladi using all precautions. If EBM is also not available, then we will think about the pasteurized donor human milk from the milk bank if it is available. Then also we have to follow the precautions, and with the precautions of feeding, we can feed with the pasteurized donor human milk. If it is not available, then we can think about formula feeding. Next slide. So this is recommendations for kangaroo mother care. These also should be promoted and practiced. For that, we have to explain that kangaroo mother care decreases the anxiety and stress of the mother, and mother and baby will get all benefits of KMC. And then mother should perform hand washing as per WHO policy before and after KMC. Mother should wear mask and follow cough etiquette and respiratory hygiene. No need to clean the chest area of mother with special disinfectant, but disinfection of frequently touched surface should be done with available disinfectant or 0.5% sodium hypochlorite every shift, and one care provider can assist the mother during KMC following all precautions of use of mask or PPE. Next slide. Next slide. So this is care of the neonates in postnatal ward of stable neonate born to suspected or COVID mother. Their mother and baby should be placed together in separate isolation room or ward and to be allowed direct breastfeeding, and hand hygiene should be before breastfeeding. Mother should perform hand hygiene, or if direct breastfeeding is not available, then breast milk expression should be done if mother and baby is unwell to give direct breastfeeding, to take direct breastfeeding. Lactational counseling should be done, and healthcare provider will take care of the mother and infant diet. But if the routine examination and monitoring of the neonate is required, then healthcare provider will wear full set of PPE using N95 mask. Next. Next. Next slide. Next. So this is so till now I have discussed about the clinical manifestations and management and preparedness for the COVID-19 among children. So another important aspect is infection prevention and control. So for every COVID care facility, there should be multidisciplinary hospital infection committee, and they will follow the strategy. All we know, this is meticulous practice of hand hygiene, respiratory hygiene, and cough etiquette by all general community people or healthcare provider. Everyone should follow this. Appropriate use of personal protective equipments for healthcare worker or healthcare professionals, family members, and patients, and placement of patient as per standard protocol and physical distancing should be followed. BMW management and management of hazardous waste as per recommended guideline must be followed. Appropriate disinfection and sterilization of patient care equipments, instrument, and linen. Sanitation, oil, ventilation, housekeeping, and spill management should be done meticulously. Standard precautions, airborne precautions, droplet precautions, and contact precaution must be practiced. Monitoring of healthcare associated infections, training of infection prevention and control skill, and strict supervision by regular use of checklists should be done. Occupational exposure management, COVID vaccination, and vaccination with other communicable disease and reporting should be practiced. And nursing responsibility following for the management of COVID children following the nursing process should be done for assessment, planning, implementation, and evaluation. Most important is for assessment of child health condition in COVID situation is history of exposure, then evaluation of signs and symptoms, physical examination, COVID testing, and other laboratory examination. Planning for holistic care of intervention should be done based on triaging area and priority health problem. Implementation should be done based on comprehensive care of the sick and affected or suspected children in home care or in the facility level. So direct patient care, assisting in treatment protocols, procedures, and respiratory support, infection prevention and control, communication, counseling, and parent or family participation, health reaching are most important responsibility of the nursing personnel. Evaluation of medical treatment and nursing intervention of the suspected and COVID confirm whether the child is deteriorating or improving or ready to go home after discharge. Discharge planning should be done based on and the documentation should be done. Key message or take home message for my presentation is children mostly acquire corona infection or COVID-19 from family members and adults. Majority of the childhood COVID is preventable with COVID appropriate behaviors. Behavior change, communication, and counseling are most important nursing interventions to prevent surge in third wave. About 2/3 of COVID-19 affected children remain asymptomatic. Evidence support that only 1 to 2% children only required COVID-19 care in intensive care unit. So our responsibility is early identification of COVID symptoms, triaging and prompt initiation of COVID management, and continuous monitoring and follow-up are the significant approach to prevent death related to COVID, long-term sufferings, and long-term post-COVID complications. Nursing personnel in community and facility level are major workforce and change agent to provide care in the and to reduce the surge of the upcoming expected COVID-19 third wave. It is our responsibility. So we have to fight this wave also with our full support, with our full hands. So this is my references. I have given all references from Government of India. So if any questions, you can write in the chat box. I'll be able to answer in that. Okay, thank you for patience listening. I think it is about so 10 minutes is over. So it is lunch time. So some I cannot summarize. So there is little disturbances also. Not that much. I think it is from my point of view. I'm sharing all this information. Thank you for patient listening.
Thank you so much, ma'am. It was indeed a very informative session, and I believe everyone have gained. And there is one question.
Can you share that question?
Is the third wave of corona inevitable?
I don't know the future. Time will give the answer till now, but everyone is predicting third wave. Yes, it can happen due to reluctancy of following of COVID appropriate behavior. It can happen, but it is not inherent. If we are following the COVID appropriate behavior, and if we are very much meticulous about this practice, then we can prevent this third wave, or we can at least reduce the number of incidents of COVID cases in third wave.
Thank you, ma'am. There is one more question. Why children below 5 years are not required to wear masks?
Because there can have chance of suffocation by the wearing of the thread, or children will not be able to cover the nose and face. So that's why, and continuous monitoring is required. And sometimes with the 3-layer mask, there can have re-inhalation of carbon dioxide. So that's why below 5 years, previously it was 2 years, but now there are so many mishaps happen. So that's why it is now recommendation from Government of India that below 5 years we will not allow the child to wear mask. We will maintain the distance. Okay. So there can have the tying with the threads, there can have the suffocation, and suffocation with the inhalation of carbon dioxide.
Thank you so much, ma'am.
Okay. Thank you.
Now the pregnant ladies can be vaccinated.
Yes, so that is the order is already there from the Government of India side. State government has to take the lead. All lactating women and pregnant women can have the. I think in next session during when that obstetric nursing discussion will be there, midwifery discussion will be there. You will get the answer. Because there is less chance of vertical transmission, there is no evidence till now that the with the vaccine there can have, or with the coronavirus also there the teratogenic effect of coronavirus is not till now identified. So that's why they are planning for vaccination of that already the Government of India issued the order to vaccinate all pregnant women. Usually that is given in 2nd and 3rd trimester.
Ma'am, hello.
Yes, hello.
Ma'am, this is Manushi. Am I audible?
Yes, yes.
Yes, ma'am. As I was going through your slides, ma'am, you have very rightly pointed out that Kawasaki disease. You know, ma'am, when in the month of March, April, when the initial 2nd wave came, so many known person of mine, their children, you know, unknowingly, they had this rise of body temperature, 3 days, 4 days. Then after that, the rashes came. Even one of my known person, her baby, the 2.5 years old child, she was admitted in an emergency condition requiring an ICU. And after that, the immunoglobulin G was given IV. You know, and then the parents, when they came to know that they has been diagnosed of Kawasaki and the baby has already been infected with COVID, they were so surprised. Like they were telling that we have not taken the child outside, neither not a single family members of us have been infected. How my child they got this particular disease? And then when this particular baby, when she was hospitalized in one of our private hospital in ICU, the doctor, the consultant was telling that this is not the first case. So many cases are coming to a hospital with the diagnosis, and after that they have come to know that the children are having this Kawasaki.
Thank you, Manushi, with sharing these practical experience. Yes, it is happening. People are not aware about that, and sometimes source of this exposure is also not able to identify it. So we have to be very much careful as a community people, as a healthcare professionals, as a nursing personnel in the clinical area. We have to be very careful about the identification of clinical manifestations. It is one of the very important responsibility, and history taking and identification of clinical presentation signs and symptoms to classify the conditions related to COVID cases and related to COVID conditions. So thank you very much for giving me this opportunity to share my experience. I think everybody will be able to enrich themselves with these slides. You can share these slides to all.
Yes, ma'am. We will surely do it. We will surely do it, ma'am. Thank you so much, ma'am.
Thank you. And references are there. They can consult with the reference for details of breastfeeding and that other management also.
Yes.
Okay. Thank you.
Thank you, ma'am. Thank you.
So I can leave now. Thank you, everyone. I can leave now. Okay.
Thank you, ma'am. Thank you so much.
Thank you.
Hey, question paper. Mera headache. Every day I'm taking paracetamol. You have? Every day I'm now started coming by bus, and you have paracetamol? No, na? Whom you will ask? Otherwise, no, I will ask the warden to send. क्या है जल्दी जल्दी दिखाओ. Again this HR is calling again. हाँ बोलो. हेलो. मेरा तो मोबाइल का प्रॉब्लम है.
அவளை இது பண்ணி அனுப்புவாங்க. இன்னைக்கு யார் வர்றா மேம்? இன்னைக்கு நீ சொல்லு ரொட்டேஷன் படி
Lily, good afternoon.
Ma'am, will start.
Yeah.
A very good afternoon to all the participants and a have you, ma'am, for today's session. Also, since the occurrence of COVID-19 pandemic, there has been a drastic change in the healthcare delivery system with the maximum number of and the resources that have been directed towards fighting this pandemic. At the same time, essential services, especially the maternal and the newborn care, have been facing several challenges. And today we are fortunate to have among us an eminent person, Dr. Lily Podarman, Associate Professor, AIMS Bhopal, who will be speaking in details about the topic recent challenges and management of maternal and newborn care during the COVID-19. We welcome you, ma'am. Dr. Lily Podarman is a very well experienced nursing personnel with a total of 19 years of experience in the nursing profession. She have completed her BSc Honors Nursing from West Bengal Government College of Nursing, Calcutta University in the year 2001, and she has completed her Master of Nursing in OBG from Rajkumari Amit Kaur College of Nursing, Delhi University in the year 2006, and she has completed her PhD in Nursing from Bharati Vidya Peeth University in. Madam is also a training of trainers IMNCI, neonatal resuscitations first golden minutes projects from Indian Academy of Pediatric in August 2012, and a trainers in the CPR Palliative Care and Training Center, Pune. Madam have been awarded with President for her outstanding performance in nursing in the year 2006, and she has contributed to the nursing profession with various book publications such as Fundamental of Midwifery, Obstetrical and Gynecological Nursing Procedure Manual, a reviewer of Target High, a textbook of mental and psychiatric nursing, and Madam have published about 19 research papers in the international journals with a high index impact factors, and she have published about 6 research papers in the national and conference proceeding, and she have had about 7 articles in the published international journals and conference. And ma'am is also a research guide and assessor for PhD, postgraduates and undergraduate students. Madam is an editorial and review board members in both national and international journals. Also, ma'am have been invited to conferences, workshop of nationals and international as the speakers. Madam have presented about 5 papers at the nationals and the international levels and awarded with ranks. Okay, so ma'am, we welcome you, and we are very fortunate to have, and we are very excited to hear about your experience and your knowledge about this particular topic. We welcome you, ma'am. Over to you.
Yeah, thank you, June. It's my pleasure to be here in this platform to share my expertise with you all. First of all, I thank Professor Mansi Sengupta, the Dean, Faculty of Nursing of Downtown University, Assam, for giving me this opportunity. And I thank all the organizers, the team who is working very hard with her to make it materialize, this virtual platform CNE. And since morning, I have seen that regarding the COVID pathophysiology, it is a very lucid and comprehensive presentation by Madam Sengupta. And after that, Madam Parul Datta has given a very and intelligent presentation on COVID-19 management of children. And now I am going to discuss about the COVID-19 management and the recent challenges what we are facing regarding management of the pregnant women. So can I share my screen?
Yes, I'm sure.
Or the security guard Lokendra koi dise jetia report tesor manu.
Is my screen visible? June?
Yes, Lily, it's absolutely visible. Yeah, you can carry on. Thank you.
Okay, thank you. So my topic is today recent challenges and management of the maternal and newborn care during COVID-19. And I have seen that Madam Parul Datta has covered most of the newborn part in her presentations. So I'll just brush up so that the participants gets the more comprehensive view about the newborn care and the management. The objectives of my presentation is to discuss the clinical profile of COVID-19 positive mothers and outcome, to describe the NICU preparedness for COVID-19, to explain the preparation before delivery, and to discuss the post-delivery mother and baby contact and the care. Now to begin with, why do we feel that pregnant women are more at risk for the COVID-19 infection? We have seen that pregnant women are having more adverse outcome than non-pregnant in terms of maternal and neonatal mortality and morbidity. Because when we talk about a mother, it is a pregnant woman, it is not only a woman, a baby is also involved in that. And there are so many factors which leads to the outcome of the pregnancy. So it comes in the maternal and neonatal mortality and morbidity. And the pregnant women are also at higher risk for exposure because they always cannot be confined to home. They have to come for their regular antenatal checkup, they have to see doctors, and if there is any warning signs or if there is any complication arises in between any pregnancy, in between the pregnancy period, she has to rush to the doctor. So pregnant women are at higher risk of exposure because she always cannot be at home. Now, the challenges in the changes in the cardiorespiratory and immune system in pregnancy also increases the woman's susceptibility, because we know the cardiorespiratory systems are compromised, and this is a immunomodulated system. Pregnancy is not an immunosuppressive condition, but it is an immunomoderated condition where there are risks for any kind of infections or any kind of morbidity can affect the pregnant woman very soon. And the potential effect on the neonatal outcome. It is obvious that if the mother is having any kind of jeopardy, it is definitely going to have an adverse effect on the neonates. Now, what are the challenges before the nurse midwives? That we have to think for, there are two challenges, logistic and the clinical issues. In the logistic, if we see, there is space, staff and supply. And clinical issues, the evidence-based recommendations. Since the time COVID-19 has come, we have been searching for the evidence which can support our management protocol for a pregnant woman with COVID-19 positive. And there are so many researches have been going on, but there is no special evidence recommendations that yes, this is the ultimate protocol for the management of COVID-19 during pregnancy. Now, if we see the clinical course in pregnancy, if we go back to the previous history, the H1N1 influenza pandemic, the pregnancy caused a higher risk of severe pneumonia, ARDS, mechanical ventilation, and death when compared with reproductive aged non-pregnant women. As we have previously discussed, that pregnant women are always at higher risk, no matter it is related to any kind of disease condition. And similar results were also reported for the SARS and MERS epidemics also. So everywhere when we found the history, it is always seen that the pregnant women are being maximum affected. Now, what we experienced so far during our first wave of COVID pandemic, the pregnant women with SARS-CoV-2 have not fared much worse than non-pregnant. We have not came across that, okay, pregnant women are very, very severely affected or they are having very bad outcome. In 2020, asymptomatic women were large in number and there were negligible vertical transmission rate. In hospitals, what we have seen, whatever the women we have approached to the hospital, they were mostly asymptomatic during the first wave, and there were no evidence of vertical transmission from the mother to the baby. And around the world, the cesarean section rates were very high during first wave, that is 52%. Now, effect of COVID-19 on the fetus. There are still no data suggesting that there is an increased risk of miscarriage or early pregnancy loss. We have not found any kind of data evidenced in our hospital at least, and we have not come across like this. No evidence of teratogenicity, and it is not an indication for MTP or change in the antenatal care, mode of delivery or the postnatal care. Now, the COVID second wave, how it was different from the COVID first wave. In 2021, as early as it may be, symptomatic pregnant women appear to be on the rise. In first wave, we have seen the pregnant women were asymptomatic, but in the second wave, the symptomatic pregnant women were on rise. Severity of the disease also seemingly little on the higher side. Absolute risk of the severe COVID-19 in pregnancy remains low, but now it is established that pregnant women are at increased risk for severe COVID-19 associated illness compared to the non-pregnant women, as per the FIGO statement in March 2021. Now, if we see the experience down the time, in the first wave from April to February 2021, the positivity rate was 5%, which increased to second wave from April 2021 onwards, it is 22%. The asymptomatic presentation were very high on the higher side during first wave, 93%. But if we see in the second wave, the asymptomatic cases are reported less, whereas the moderate to severe symptoms cases were higher side. So if you can see the purple line, that moderate to severe disease, which was very low during the first wave, 1.5%, which is increased to 14% during the second wave. And though the pregnant women who were moderate to severely ill, they require high flow nasal cannula, non-invasive ventilation or invasive mode of ventilation, steroids, heparin and remdesivir. Now, categorization of the COVID-19 in pregnancy. I have already mentioned that pregnancy is an immunomodulator state. It is not, please remember, it is not an immunosuppressive state. It is an immunomodulator state. So ICMR guidelines says that consider all pregnant women in the category B. And a thorough history, especially about the COVID symptomatology, extensive review of records, and a well-done general and obstetrical examination is must before further categorization of the pregnant women who are approached to the hospital with COVID-19 symptoms. Now, these are the clinical categorization: category B1, category B2, and category C. We have started with B because ICMR have already told that you have to consider all the pregnant women in category B. So category B1 says the pregnant women who are asymptomatic or who are represented with very, very mild symptoms. And category B2, those who are having influenza-like illness symptoms like fever, cough, sore throat or diarrhea or fatigue, or those with comorbidities like hypertension, diabetes, liver disease and the renal disease. So the category B belongs to those pregnant women, those who are presenting with some influenza-like illness symptoms. And the category C, those who are pregnant women who are breathless and who are presented with chest pain, drowsiness, hypotension, hemoptysis and cyanosis. This is all the red trial symptoms or the red flag symptoms, sign symptoms. Now, clinical severity, that is mild, moderate and severe. In wave 1, it was all the pregnant woman belongs to mild, whereas in the second wave, the pregnant woman belongs to moderate to severe kind of illness. So in the mild, we can see the presentations were like no breathlessness, no hypoxia. The respiratory rate was also absolutely normal, within normal limit. That is less than 24 breaths per minute, and SpO2 also was on a higher side, more than 94% in room wear, and otherwise the pregnant woman does not have any symptoms. But the moderate, when we look into the women present with dyspnea, hypoxia, respiratory rate on a higher side, 24 to 29 breaths per minute, SpO2 91 to 94 in room air, and along with fever and cough. When it goes into severe, the dyspnea and the hypoxia continues, respiratory rate more rises, more than 30 breaths per minute, SpO2 goes below 90% in room air, tachycardia, that is more than 125 beats per minute, with or without pneumonia. Now, when to admit a woman and where and how to manage. Category B1, the woman fulfilling criteria for home isolation can be allowed for self-isolate because the hospital itself a risk for nosocomial infection and hospital associated infection. So it is better if the women are fulfilling the criteria for home isolation and they are being educated well to maintain the quarantine guidelines as per ICMR. So it is better for them. There should not be any obstetrical indication also for her admission. The obstetrical examination and the general history and the general symptomatology of the pregnant woman should be also very clear, and that the woman does not need any admission of at the hospital. The dietary advice should be given properly to maintain, and then avoidance of total bed rest must be emphasized. I mean, the total bed rest should be avoided. The mother can be ambulated. It is not that she is COVID infected or she is representing with influenza-like symptoms and she should be on the bed rest. No. There is no evidence to support measurement of coagulation marker, including D-dimer, in non-hospitalized patients with COVID-19. We need not go for any kind of investigations if the mother is asymptomatic and the mother is fulfilling the criteria for home isolation. But they should be taught, or they must be educated, that the pregnant women should report to the nearest facility if they become symptomatic or if they have fall in the SpO2 less than 94%. Along with that, if there is any other obstetrical emergency arises, they always should approach to the hospital facility. They must be taught to do walk test. Now this is walk test, whereby they walk for 6 minutes or take 40 steps and are told to measure the SpO2 before and after. A fall more than 3% from the baseline in the SpO2 level is significant and they must report to the health facility. Like, for the pregnant women, we teach them about the daily fetal movement monitoring. So they count the fetal movement, and then if there is any deviations from the normal count, they report to the hospital. So here also for the COVID-19, you must be teaching them DFMC as well as the walk test. That is, they have to walk for 6 minutes or 40 steps and measure the SpO2 before and after. Now comes the category B2. These women need indoor evaluation and symptomatic treatment, because the category B2 generally comes into the moderate symptoms. Treatment may include paracetamol, anti-TSUIPs in the addition to the routine iron, calcium and folic acid, because they represent with fever, they represented with cough, they represented with hypoxia, dyspnea, all these things. So laboratory investigations are must here, that is CBC routine things what we carry on for everyone. That is CBC, RFT, LFT, RBS, serum electrolytes, ECG and CRP. Now for the X-ray, because they may represent with pneumonia, they may not represent with pneumonia. So it may be advisable to ask for an X-ray, just X-ray PA view with the lid shielding of the abdomen in all cases who have persistent cough, because they may go into the severe category. Now the additional markers like D-dimer, ferritin, CPK may be sent if the symptoms persist more than 5 days. Now budesonide, that is a corticosteroid, 800 microgram can be started twice a day if symptoms persist beyond 5 days of the disease onset. And recording of the vitals, SpO2, walk test and review of symptoms should be monitored thrice a day. It is very, very important. Whenever a mother is in the hospital, it is the nursing responsibility that vitals monitoring, SpO2 monitoring, walk test and the other symptoms review should be done every 3 hours, thrice a day, means every 8 hourly. Now, once the patients have been walked up and are stable with subsidence of the symptoms, they can go into home quarantine with same checkup and detail for the others in quarantine. Okay, so after all this treatment, when the patients are settled down, they can be sent on home quarantine. Now the category C, that is all severe cases. So these patients require multidisciplinary care and must therefore be admitted in the COVID designated hospital. History taking, especially with regard to the COVID symptomatology, extensive review of the record and very well done general and obstetrical examination is must for this kind of pregnant women. Now, these are the laboratory investigations we can see at admission. What I have already told, that CBC, RFT, LFT, CPR, RBS, electrolytes, ECG and pulse oximetry regularly has to be done for every pregnant woman. Now, if clinically indicated, means symptoms persisted more than 5 days, then portable chest X-ray can be done. D-dimer, ferritin, LDH, CPK and blood culture, TROP-T, TROP-I, HRCT, thorax. These all are when it is indicated, not regularly. To repeat every 48 hours if clinically deteriorating. Then CBC, creatinine, AST, ALT, CRP, LDH, etc. And for the immunocompromised patient who are pregnant with some other comorbidities like transplant recipients or HIV, they have to do the test to rule out the opportunistic infections. Those who are already immunocompromised from the beginning. Now it comes the matter of respiratory support, for whom we need and what to be provided. For the mothers who are asymptomatic or mild infections, they have to be on supportive treatment. But for the moderate illness, inpatient observations as up to 40% may progress to the severe illness. And those who are severe to critical illness, the inpatient treatment, adequate respiratory support, managing comorbid condition and coordinating with the safe delivery in coordination with the specialist. Because the mother, we have to take a multidisciplinary approach in managing the pregnant women with severe and critical illnesses. There, because the delivery is not always a relieving matter for the COVID-19 symptoms. As we have seen that if the mother is pre-eclamptic and severely pre-eclamptic, as soon as the delivery occurs, the mother becomes normal. But here it is not a case that if the mother is COVID-19 positive and the mother is severely ill and the mother is delivered, the symptoms is going to be relieved. Here the most important factor is the respiratory support and the ventilation. Now consideration of the steroid. So steroid, I have already told that budesonide 800 microgram already it is started when the symptoms persisted beyond 5 days. Now the parenteral and the oral steroids are indicated when there is shifting from the moderate to severe rise in respiratory rate, fall in SpO2, and in the walk test, we have seen that there is desaturation gone up to 3%, bronchopneumonia present, and marked rise in the pro-inflammatory markers with the symptoms. For all these cases, we have to start with the steroid. Now the COVID-19 therapies. Efficacy of the antiviral and biologic agent for COVID-19 in pregnancy remains unclear. It has to be given or not and what to be given. But still, the decision is to be made in consultation with the infectious disease expert in accordance with the institutional protocol following the discussion of potential benefit and risk with the patient. How much it is going to be benefited and how much it is going to bring risk to the patient and the neonate, that means the mother and the baby. Antibiotics are generally given, that is azithromycin and ceftriaxone or other higher antibiotic is considered if the patient are with increased count of CRP. But the remdesivir, this is the dose generally given 200 mg IV on a day 1 and followed by 100 mg IV daily into 4 days. It is indicated with category C, that is the severe symptoms with bronchopneumonia and not responding to the steroids and the oxygen therapy. So for category B, we have started with steroid and oxygen therapy. The supportive oxygen therapy is given, but remdesivir is given for the mother who have shifted from the moderate to severe and the symptoms were not relieving and they were not being responded to the steroid treatment and oxygen therapy. But this remdesivir may be offered on compassionate basis with written informed consent. It needs to be started with 10 days of onset of symptoms. After 10 days, the steroid started after 5 days, and remdesivir, if it needs to be started or indicated to be started, it needs to be started after 10 days. RFT, LFT and creatinine clearance is must when the patient is on remdesivir. But the other antiviral therapy, that is ivermectin and the favipiravir, is contraindicated during pregnancy. And it is also mentioned by madam in the previous presentation that it is also contraindicated for the children. Now, when do we take decision for the delivery? It is purely on obstetrical ground, because we have said the COVID-19 is not an indication for the termination of pregnancy. Decision to be taken by the multidisciplinary team and to be considered beyond 26 to 28, that is after period of viability, on decision to be on individual basis if the patient is deteriorating and not responding to NIV and if non-invasive invasive ventilation is needed. Delivery does not always improve the maternal ventilation or prognosis in a critically ill patient. I have already mentioned that the termination of pregnancy is not going to improve the condition of the mother or the prognosis of the mother. So priority is given to adequate respiratory support or the ventilation with frequent assessment of the clinical worsening as long as the fetal status is reassuring. So we can continue with the pregnancy until and unless the fetus is not affected and the fetal status is not indicated for emergency delivery. Now comes the intrapartum care. Delivery definitely to be conducted in a dedicated COVID labor room. Handheld Doppler CTG devices for fetal monitoring is must. SpO2 to be closely monitored along with the other routine parameters monitored in labor. And if LAC is indicated or needed, the decision needs to be taken very earlier than usual. Generally, we take half an hour before, but here if LACS is needed, we have to take very prior decision so that the labor room preparations, the OT preparations, the mother's preparations, we have to prepare for the baby's resuscitations also. So it need time. So the decision has to be taken on an earlier basis. Now the postpartum care, breastfeeding permitted, as everyone knows now, the lactating, the pregnant women after the delivery, they can breastfeed the baby with some protocols and ensure hand hygiene and respiratory hygiene. Post LACS patients to give low molecular heparin 40 mg into 10 days, and patients teaching for administration of low molecular heparin at home also can be given. An antibiotic prophylaxis as per the choice of doctor and the institutional protocol to be started. The vaccination, COVID-19 vaccination for the pregnant and the lactating women, the recent guideline says that yes, the pregnant woman and the lactating mother can go for COVID-19 vaccination as per the protocol given for the other. Now, it is the suspected COVID-19 pregnant women, those who are suspected, what we should do for them. The pregnant woman with exposure to COVID-19 or travel to red zone or the containment area during last 2 weeks should be isolated by using the guidelines which is for the other non-pregnant adults. Now, in absence of community spread, isolation at the designated facility, and in the presence of community spread, the isolation by home quarantine may be preferred. It says that if the mother is suspected and there is no community spread, then she should be isolated in a designated area. But if there is community spread, she should be at home. For the home quarantine, the guidelines are same. It is used by the ICMR and ministry. The testing for pregnant women should be done as per the ICMR guidelines. In addition, the pregnant women residing in cluster and the containment area or in large migration gatherings, evacuation centers from the hotspot district presenting in labor or likely to deliver in next 5 days should be tested even if asymptomatic. It means the pregnant women who are residing in the containment area or any hotspot area which is designated by the ministry or the district or the state, and they are approaching delivery very near, then they should be positively tested. I mean, they should be definitely tested for COVID-19 even if they are not represented with any kind of symptoms. The pregnant women with confirmed COVID-19 should be managed with supportive care recommended for non-pregnant adults. And the current guideline by the Government of India do not recommend use of hydroxychloroquine, chloroquine or antiviral drugs in pregnant women. That also I have already mentioned. The management includes oxygen therapy, respiratory support for the treatment of hypoxemic respiratory failure, fluid therapy, antibiotics and management of shock. Antiviral therapy, already we have told, I have already mentioned that it is contraindicated, but we can give remdesivir and after a very lucid, what I will say, the decision by the multidisciplinary decision. And then when providing healthcare to women in labor with suspected or confirmed COVID-19, the standard universal precautions to prevent the contact with body fluid should be maintained. In addition, we have to use the proper PPE and reception and the triage should be done in the same room that is to be used for admission in the labor and delivery, and it should be a room with negative pressure. The room should be free from any unnecessary items which could act as an infected fomites later. There should be a restrictions of the visitors, restriction in the number of attendants, and there should not be any staff also who are not essential to be present there. There should be facilities for healthcare providers to remove and safely discard the PPE at the exit. That means donning and doffing room should be completely separate. COVID care facilities should be identified in the public and the private sector. These must be large multi-speciality hospital with adequate space, infrastructure and logistics. And the referral pathways also should be well established. When the symptoms, if it is manageable, they can be treated. But if they are out of manageable of that particular area, they should be referring to the tertiary care hospital or the designated care hospital very soon. In such COVID care facilities, there should be 3 demarcated zones: clean zone, potentially complicated, contaminated and contaminated, each housing all the needed equipment and services for the women and neonate for the management of the COVID-19 suspected, non-COVID and confirmed COVID-19 mothers. The standard and the facilities required for the infection control in these areas should be same as that for the other adult with suspected and confirmed COVID-19. The universal precautions are same for all. It is either pregnant or either non-pregnant women. There is no change. Now, every pregnant woman should be triaged at the entry and then allotted into one of the 3 zones. So the reporting area and the triaging should be done in one room, and after that, depending on their symptoms, they should be sending to the 3 different zones: clean, contaminated and non-contaminated zones. I mean clean or non-contaminated, suspected and contaminated. In case of who deliver in a non-COVID facility turns out to be COVID-19 positive after the delivery, then action should be taken as per the Ministry of Health and Family Welfare's guidelines. It is on the detection of suspect confirmed COVID-19 cases in a non-COVID health facility. Mode of delivery in a pregnant woman with suspected or confirmed COVID-19 should be guided by her obstetric assessment and her physiological stability. That means it is not that if the mother is COVID-19 positive, she has to go for LSCS. Somebody has raised hand. Rajkumari Binoya. Should I stop June? Or we will be addressing her later?
We'll be addressing her later.
Okay, thank you. So the mode of delivery we were discussing that, okay, if the pregnant woman is COVID-19 positive, that does not mean the mother has to undergo LSCS. It has to depend on the obstetrical assessment and the physiological stability, that is cardiorespiratory status and the oxygenation. COVID-19 itself is not an indication for induction of labor or cesarean section. Now, continuous electronic fetal monitoring to be done during the labor, which I have already mentioned. And if the facilities for the continuous electronic fetal monitoring are not available, then manual monitoring by the frequent auscultation of the fetal heart rate should be done during labor as indicated for a high-risk delivery. But it is very difficult when we wear the PPE and the mother is also, sometimes it is designated by the institution that mother also has to be in PPE. But still we should try our level best for the manual monitoring of the fetal status. Adequate equipment and trained healthcare providers should be available for intrapartum monitoring and obstetric interventions as indicated in the separate childbirth facilities for infected pregnant women. The obstetrician has to be trained, and of course there should be a midwife present in the labor room when we are managing a infected pregnant woman. Oxygenation status of the woman during labor should be monitored by a pulse oximeter, and oxygen therapy should be titrated to maintain oxygen saturation for more than 94%. All the monitoring, intrapartum monitoring during the labor should be carried out. Along with that, oxygenation status also to be carried out by the pulse oximeter, and mother should be on oxygen to maintain the saturation more than 94%. Now, appropriate staff, it is very, very essential that identify an ICU team member who would enter the delivery room. I said that the delivery room would be a negative pressure room, and there should be the clearly designated staff should be available. There is no unnecessary staff, there is no unnecessary attendant, etc. So identify the backup team who stays outside the room unless it is needed. Clear planned communication chain for those in and out of the delivery room. When it is needed, what it is needed, everything should be properly communicated between these two teams. Identify the role of team member at delivery and keep a log of every healthcare provider entering and exiting the patient room. Now here the pictorial representation of the delivery room. Here we can see that the delivery and operating room is negative pressure room preferably, and there can be a facility for the virtual interaction with the partner. The mother is on mask, and then if there is any aerolization procedure are likely, of course the patient, the healthcare provider is also on a whole PPE and the mask. There should not be any skin to skin contact between the mother and the baby after the delivery. Delayed cord clamping is practiced. PPE, goggle, mask, gown and glove should be worn by the healthcare provider. Minimal number of providers in the room. And the outside the delivery room, there are resuscitation equipments are kept, transport isolates are kept, and the additional healthcare providers are waiting outside for as a backup. Now the isolation status. Appropriate isolation room for delivery, that is airborne infection isolation room for patients who may require aerosol generating procedure, should be a separate one. Neutral pressure room with HEPA filter if uncomplicated delivery expected with door closed. But clear signage outside the room regarding the infection precautions are needed. Now the PPE. Disposable patient examination gloves should be available. Disposable isolation gown should be available. For the respiratory protection, the N95 mask or the high level respirator face mask appropriate if no aerosol generating procedures are there. An appropriate eye protection, that is goggle or the face shield, should be available, adequate in number for all the staffs who are attending the delivery. Equipment and medicines for the delivery and transport procedure also should be available, that is boxes, supplies checked, code art, supplies, code card, supplies, bag and mask, neo puff, electrocardiogram facilities, umbilical lines, everything should be ready. Transport isolate also checked and ready to use. Medications checked and ready. If not in the code card, that is epinephrine at the normal saline. Everything should be ready for emergency, to attend the emergency at any time. But it is not mandatory to be delivered at the delivery, to be present in the delivery room. They can wait outside at a separate team. If the emergency arises, it can be addressed. Now the NICU preparedness for COVID-19. In the face of growing pandemic with COVID-19, there is an urgent need of proactive preparation and planning to combat COVID-19 in the vulnerable patient population in the neonatal intensive care unit, and to safeguard the patient, their family and the healthcare personnel taking care of them. Yes. Care of neonate born to the pregnant woman with suspected or confirmed SARS-CoV-2 infection. We can see here. In the children hospital, when the mother is presented with the influenza-like symptoms and testing for SARS-CoV-2 infection, then the negative pressure room, what I have already shown to you, that mother is on the mask and no skin-to-skin contact, delayed cord clamping by the provider holding baby without maternal skin contact, and limit the providers in the delivery room or to minimize the exposure. Now it has to be a shared decision with the parent that how to take care and how to what would be the strategy to promote infant bonding with the parents. Now, strict isolation strategy to limit risk for transmission to the neonate, that is the neonatal resuscitation and the further care in a separate room, followed by the bath if the baby is stable, and placement in an isolate. And neonatal resuscitation in the same room also can be conducted, but the distance be between more than 6 feet, and it should be divided by a curtain or any kind of physical barrier can be put between these two areas. But it again has to be followed by a baby bath if the baby is stable. Now, when we think about the nutrition, it is also a shared decision making with the parent to discuss 3 choices. There are 3 choices. First one, they can go for formula or the donor milk available. The pump and discarded the EBM if the mother desired to breastfeed, and the clean breast or express breast milk with precautions, and EBM is fed by a healthy caretaker to the baby. Mother can breastfeed the baby and clean with PPE, clean the breast before breastfeeding. Now, when the baby can go for COVID-19 testing. Here one thing to important, see there is one star mark, that is direct breastfeeding with PPE also can be resumed after 2 negative maternal COVID-19 test negative aparting 24 hours and resolution of the fever or symptoms, or if the infant is also positive for SARS-CoV-2. That means it depends on the mother's choice. If the mother wants, she can directly feed the baby with PPE, but she has to be presented with 2 negative reports aparting 24 hours. And if the baby is also positive and the mother is also positive, then she can always feed the baby. Now, testing for SARS-CoV-2, it has to be done after 24 hours and within 48 hours after the birth. For that, nasopharyngeal swab and the oropharyngeal swab also can be taken, or tracheal aspirate can be taken if the baby is intubated. Now, the discharge process in the asymptomatic infant. Discharge to a healthy caretaker until mother has resolution of fever, plus improvement in the sign and symptoms, plus 2 negative SARS-CoV-2 tests more than 24 hours apart. If the baby is healthy, but the mother is positive, then the baby can be discharged to a healthy caretaker until and unless the mother represent with this criteria, that is fever is resolved, there is improvement in the sign and symptoms of the mother, and the mother is having 2 negative COVID-19 report more than 24 hours apart. But and the mother is positive and the baby is negative, then retest the infant within 2 to 3 weeks. Next come discharge to the mother with contact and droplet precautions until mother has resolution of fever plus improvement in sign and symptoms plus 2 negative SARS-CoV-2 test more than 24 hours apart. If the mother and baby both are positive but asymptomatic, then they can be discharged together. But after that, close follow-up of the mother and infant, though video visit and the telephone calls are very, very important and necessary. Now the newborn resuscitation. If possible, the resuscitation of the neonate should be done in a physically separate adjacent room earmarked for this purpose. It is also, I have already told previously, the resuscitation can be done in a separate room. If not feasible, then the resuscitation warmer should be physically separated from the mother's delivery area distance, at least that is at a distance more than 6 feet or 2 meters. Minimum number of personnel should be attained and wear a full set of PPE including N95 mask, and mother should perform hand hygiene and wear triple layer mask. Delayed cord clamping is practiced. Skin to skin contact also can be practiced if it is indicated. It depends on the obstetrician and the pediatrician and the institutional policy. Neonatal resuscitation should be followed the standard guidelines. Endotracheal administration of medication should be avoided, and indications for intubation shall not change because of maternal COVID-19 status. Bathing is not recommended in view of the risk of hypothermia and hospital acquired infection, but we have already seen that the protocol says if the baby is stable, we can provide bath and then the resuscitation measure can be taken. We can see here the physical barrier or the curtain if resuscitation is performed in the same room with the mother more than 6 feet or 2 meters away. Resuscitation as per it has to be as the NRP guidelines to be followed. The incubator with the hood elevated with the heating source should be present. Airborne precautions for aerosol generation procedures such as intubation. That time the healthcare worker has to be with N95 mask, goggle and the face shield, double gloves and gown, and the resuscitator should be very, very experienced one. These are the triaging system. Triage of the newborn, that is the mother tested for COVID-19 positive. Yes, then it go for test result. If the mother is negative, then is the mother symptomatic or with confirmed exposure? It is again, if it is yes, then mother to deliver in the designated care center, delivery center. The newborn delivery is the newborn more than 35 weeks. Then the newborn symptomatic or the newborn has any illness. If it is yes, then admit to the appropriate service. And does the newborn need AGP? Then admit to the standard. If it is no, then admit to the standard precautionary center in droplet and with droplet precautions. Actually, I think this guidelines can let them say to the audience. It will be better for them to understand. They can see the chart very nicely and follow it. Okay. Now the post-delivery mother and the baby contact, that is, we have to follow the precautions. Mother and baby should be placed in a separate isolation rooms. Healthcare workers should follow all the possible precautions and wear PPE. Newborn should be bathing should be done for the newborn immediately and limit the visitor. Now infant post-delivery isolation, transport in an isolate with door closed. Infant placement, airborne infection isolation room. If requires respiratory support, the infant should be placed in that particular room or designated room, or the neutral pressure room with HEPA filter if no respiratory support required or the expected. and clear signage outside the room regarding the infection precautions needed before entering the room. I have already mentioned everywhere that appropriate staff should be done. There should not be any unnecessary staff inside the room. They should be waiting. There should be two teams. One is waiting inside, another one is working outside. So there should be a communication, clear communication between these two teams. PPE, disposable patient examination gloves should be available. Disposable isolation gown should be available. Respiratory protection, appropriate eye protection, equipment dedicated for the disposable non-critical patient care equipment, everything, all the equipment required for managing cleanliness, disinfection on the COVID appropriate protocols, it has to be present in the area. Now, those who are stable neonates but exposed to COVID-19. The stable neonate exposed to COVID-19 from the mother to other relatives should be roomed in with their mother and be exclusively breastfed. For the supporting lactation, nurses trained in essential care and lactation management should be provided. A healthy asymptomatic willing family member who is not positive for COVID-19 and has been in direct contact with suspected or confirmed COVID-19 person may be allowed to provide support to the mother and the neonate. Mother should wash hands frequently before the breastfeeding and wear the mask. The mother-baby dyad must be isolated from other suspected and infected cases. If the rooming is not possible because of the sickness in the neonate or the mother, the neonate should be fed expressed breast milk or the mother by a nurse or a trained healthy family member. The EBM can be fed by the non-sick family member or by a healthcare worker. If safe, the early discharge to home followed by telephonic follow-up or the home visit by a designated healthcare worker may be considered. These are the testing strategy. History of exposure to COVID-19 positive adult. It should be done. Mother had COVID-19 infection within 14 days before birth. And if there is any history of contact with COVID-19 positive person in the postnatal period, then the baby has to go for test. The timing at birth, if the mother had COVID-19 or a detection of history of contact with COVID-19 positive person in the postnatal period. If a sample is not obtained at birth due to logistic reason, it should be obtained as soon as possible. Rooming in should not be postponed if testing is delayed. If the first test is negative, a repeat test should be done after 5 to 14 days of exposure. Now, irrespective of the history of exposure, presenting with pneumonia or severe acute respiratory infections that require hospitalization with onset at more than 48 to 72 hours of age, unless there is another underlying illness that completely explains the respiratory signs and symptoms. Those who are represented with respiratory distress symptom, they have to definitely go for the testing irrespective of the history of exposure. Now, the features that suggest acute respiratory illness in a neonate are respiratory distress with or without cough or with or without fever. So, in all these cases, baby has to be tested positively. Now, the respiratory support with suspected and confirmed COVID-19. The CPAP should be preferred over NIPPV and high flow nasal cannula. Contact and droplet isolation and wear N95 mask while providing care in the area where neonate with suspected confirmed COVID-19 are being provided with respiratory support. Intubation should only be for usual indication and consider use of pre-medication for non-pregnant into non-emergent indication, and intubation should be performed by the experts. Consider use of aerosol box during intubation and suction inline suction device and HEPA filters. The area providing support should be a negative air pressure area. Specific anti-COVID-19 treatment is not recommended in symptomatic neonates. This is already mentioned in the previous class. And use of adjacent therapy such as systematic corticosteroids, intravenous gamma globulin, and convalescent plasma is not recommended in symptomatic neonate with suspected or confirmed COVID-19. Now, the disinfection of the surface where children and the neonate care areas with suspected and confirmed COVID-19. Wear PPE before disinfection. If the equipment or the surface is visibly soiled, first clean with soap and water or the soaked cloth, and 0.5% sodium hypochlorite can be used to disinfect large surface like floor and wall at least once per shift, and for cleaning after the patient is transferred out to the area. 70% ethyl alcohol can be used to disinfect small area and equipment between the uses. Hydrogen peroxide can be used to the surface cleaning in incubators, open care system, infusion pump, weighing scale, standby equipment, ventilator, monitor, phototherapy, etc. And hydrogen peroxide only to be used when equipment is not being used for the patient. For ensuring the efficacy of disinfection with H2O2 use, the contact period recommended by manufacturer. Generally, it is 1 hour. And if the baby have confirmed or suspected COVID-19, can I provide breast milk for my NICU baby? And the answer is yes. Already, women with COVID-19 can breastfeed if they wish to do so. They should practice respiratory hygiene and wear a mask, wash hands before and after touching the baby, routinely cleaning and disinfectant of the surfaces to be followed. Now the discharge policy, the suspect neonates, the stable neonates exposed to the COVID-19 and being roomed in with their mother may be discharged together at the same time. Stable neonate in while rooming in is not possible because of the sickness of the mother, and those who are being cared by a trained family member may be discharged from the facility within 24 to 48 hours of age, those who are stable. But those who are positive, then asymptomatic neonates or those with mild to moderate clinical course whose symptoms and need of oxygen within 3 days can be discharged from the hospital after 10 days without repeating the RT-PCR test. But in the severe cases, a single negative RT-PCR should be demonstrated after resolution of the symptoms prior to discharge. Healthcare professionals who are working in the childbirth or the neonatal area should report to their supervisor if they have respiratory or the other symptoms suggestive of COVID-19. And the healthcare professionals who are directly involved in the care of patients with suspect or confirmed COVID-19 infection may consider taking hydroxychloroquine prophylaxis as advised by Government of India. Now follow the routine immunization policy for the healthy neonates born to a mother with suspected or the confirmed COVID-19. This is very important. And in neonates with suspected and confirmed infection, vaccination should be completed before discharge from the hospital as per existing policy. The follow-up should be done as per the institutional policy, either home isolation to be followed, and the retesting can be done if it is indicated. I think it is done, and the source, the references, it is all the guidelines which is available by the ICMR and by the Government of India and by the Ministry. And thank you for this is the end of my presentation. Thank you all the audience for your patience listening. You can put up your questions and we can discuss. And the platform is handed over to June. Thank you.
Thank you so much, Lily, for your excellent in-depth deliberation. So sorry for the apology. As I told you, I have some other meeting in progress. So I will take your